So it's really our pleasure. Jen and I have been doing this together for probably a decade. So this is wonderful too. I think this is the first time we've spoken to anyone in Virginia. So thank you all for being interested and for expanding your learning on behalf of your clients and yourselves. Okay, so what we're going to do today is we're going to have someone else advancing the slides. So it'd be great if I could see the slides. And then what we're going to do is talk through a little bit about CBT for psychosis using a case-based sort of teaching approach. So what we'll do is we'll introduce you to a few cases, and we'll thread those cases throughout the entire workshop. So I am just waiting for the slides to be shared so that I could see them. Hannah, do you have the capacity to share them?
Hannah might be on mute.
Anything in chat. Sorry guys for the...
I'll just jump in with a couple other little housekeeping things while we're getting the slides up. So as far as the handouts go, as we kind of go through today, we'll be, especially when we get to kind of the nuts and bolts of CBTP, you'll hear us talking about different ways of doing some assessment and some different worksheets for voices and paranoia and things like that. And as much as we can remember while we're coordinating all of this, we will let you know when we're alluding to or we mention a handout that you all have in your packet. So if you have them available, you can follow along, but otherwise just know that you have access to that particular worksheet.
Okay, excellent. I know that Hannah needed to be, the toast needed to be transferred to Hannah. So thank you, Hannah. Okay, so we can start with the next slide, which will give us a little bit of a sense of our workshop agenda. So today what we're going to try to cover is sort of why cognitive behavioral therapy for psychosis, what's the rationale for learning this treatment and who is it for, to get into this general structure and philosophy of cognitive behavioral therapy for psychosis, what we sort of call the spirit of cognitive behavioral therapy for psychosis. As I mentioned, we will use 2 client examples that will kind of root our learning in case-based material. And so when Jen and I are doing role plays or when we demonstrate handouts, we're going to be referring to these 2 particular cases as examples. We'll talk a bit about how do you conceptualize psychotic symptoms in CBT. So it's a bit of the theory, but we're going to talk about it in a way that you can share it with your clients. So they understand what you're doing and where you're going and what's the rationale for your interventions. And then we hope to also be able to talk through some of the early treatment phases in cognitive behavioral therapy for psychosis. So we consider the first phase to be an engagement phase and then an assessment phase. And that's what we're thinking about for today. Tomorrow, we will go into, we'll continue for the next slide to thinking a little bit more about case conceptualization and how to goal set. And then we'll really dive in more to the interventions, the actual approaching the problems on the problem list. What do you do about psychotic symptoms? How do you address them from a CBT framework? And then some discussion on generalization of skills and relapse prevention, but we're not going to be heavy on those because there's so much to get through just in the first few phases. And then we have some opportunities to talk about challenges. I think as Natalia mentioned, for questions, what would be great is if you can type them into either the chat or the Q&A box. The Q&A is a little better because it helps us kind of organize ourselves about which questions we've addressed. What we'll do is before the break, and maybe perhaps even after the break, if questions come in, we will consolidate the questions and address them, and then also at the end of the day. So we'll keep a running tally there. Okay, so why don't we get started? So the first question is why CBT for psychosis? So I think it's really important to recognize that if we go to the next slide, people with psychosis really want to play an active role in their treatment. And perhaps historically, for example, when I went to graduate school, I was told that I was trained in CBT, But I was really told that CBT wasn't for people with schizophrenia. That was the thinking back then. And I think some of it had to do with the idea that people were not able to be kind of active and collaborative in the way that CBT requires. I think there was also more therapeutic pessimism around treating schizophrenia and psychotic disorders. But that's not how we think anymore. And we also recognize that medication is important. So far, we do not have treatment models that actually work in this country without medication. There are some models that work in other countries, but we won't go into those. But they don't seem to work here. So medication is a foundational piece of treatment for schizophrenia spectrum disorders. But we know that many people, perhaps as many as 40%, continue to have residual psychotic symptoms on medications. Medications also don't address a range of other symptoms that are part of schizophrenia, negative symptoms, cognitive deficits, etc. And so there are cognitive behavioral therapy interventions that can help people get more out of their treatment and recover more fully. Because we know that CBTP from evidence does improve psychotic symptoms and does decrease distress associated with those symptoms. So the evidence base for CBTP, we're not going to go into it in a huge way, but we're going to talk about, the most recent meta-analysis, at least on this, really shows that there is a pretty statistically stable evidence base at this point for cognitive behavioral therapy for psychosis. It seems a little more effective for hallucinations than for delusions, actually, but we see small to medium effect sizes on delusions, general, and negative symptoms, even when negative symptoms aren't actually being targeted, which is really kind of interesting. So it seems to have broad spectrum effects. It seems to be pretty beneficial. We're not looking at huge effect sizes, but I think sometimes to put it in perspective, it's helpful to think about what is the medication, what is the effect size of antipsychotic medication. The effect size of antipsychotic medication is about 0.6. So if we go to the next slide, we'll see a little bit where the evidence leads us to think about, now when you're comparing, CBT to like a treatment as usual, that might be a less, that's easier to find an effect, right? Because treatment as usual isn't maybe a manual-based, very systematized treatment. So that's what TAU is here, and I'll orient it to the slide in a minute. Versus like an active control, which is AC. An active control is like another treatment. So it might be compared to something like psychoeducation or even something like social skills training. So effect sizes of about 0.4 is sort of on the right on the cusp of medium, small to medium. What we see if you look at this slide, which is comparing CBT for to either treatment as usual or active controls, you see that for hallucinations, that's the first blue bar here, and the gray bar, the effect size is about the same. It's about 0.34. And for delusions, which is the green and the sort of more swimming pool blue, the effect sizes are 0.23 or 0.37. So what we're getting is a pretty consistent picture of an effect size of about 0.3 for schizophrenia. So it's important that we don't oversell the benefits of CBTP. But what this slide shows us is if we don't have something better, this is outperforming other active treatment controls. So it's something to it's certainly something to offer people. Okay, next slide. So it's also important to think about, well, who does research apply to whenever you review things like meta-analyses and such? This is not every single person with schizophrenia who's consenting to be in these research studies, right? These are people who are willing and able to give informed consent. These are outpatients typically. They're help seeking, and that means that they have some distress. It is very difficult, and people who work with schizophrenia have certainly seen cases where it's harder to find the distress. It's harder to find something to kind of grab hold of and work on together in treatment, because a person may not you know, they may find their psychotic symptoms, they may be disabling, but they may not actually be worried about them or as concerned about them. So you might be seeing people who have, you know, who are a little bit different from the full range of people with psychosis. The other thing that's really important is that these are people who are already on antipsychotic medication. These are not untreated people. So, you know, we know that most people are not taking their medicine exactly as prescribed. That's just true for the entire population on all medical conditions, and it's also probably true for most people with schizophrenia. But they are taking some medication. So this is ancillary treatment. This is not instead of medication. So this has led to thinking about, you know, best practice guidelines in the United States and in other countries. And just to kind of pull out the best practice guidelines, the most recent guidelines that have been published in the United States are the PORT guidelines, the patient-oriented research team that comes out of the University of Maryland. And this is their statement from, at this point, more than a decade ago, which is really, you know, sort of encouraging on the one hand that there was this recognition a decade ago of how important CBT approaches were for people with psychotic disorders. On the other hand, when we think about the actual penetration of CBT for psychosis and how many trained people there are in the United States to offer this and how many people are actually getting CBT for psychosis, it's a very small number. So this training today hopefully goes somewhere towards addressing that. And this just points out, you know, some of the sort of caveats or situations in which CBTP should be offered. So the idea is that people who are receiving adequate pharmacotherapy and continue to have residual psychotic symptoms should be offered a course of cognitive behavioral therapy. Group and individual approaches have been pretty similar in their efficacy. So it could be individual, it could be group. It should be about at least 6 months. So 4 to 9 months is the standard here. And then it lists some of the key elements of the intervention, which are all things that we're going to review today in the training. Thank you. Next slide. All right. So we're going to talk now about the spirit and philosophy of CBTP, and Jen is going to take this section over.
Great. Thanks, Corey. Let me just say hi to everyone since I didn't get to quite do that yet. So just to echo Corey's sentiments, we are really delighted to be here, and thank you all for taking the time out of your schedule, which is way more complex probably than it ever was with parenting and caregiving and house chores and regular clinical work to be at home and do this. So we're very excited with the number of people who signed up and the number of people who are on. We're very excited to kind of share this overview with you. And a huge thank you to Natalia for getting us organized and David for helping with the tech. And Hannah, who's part of our group, for moving our slides along for us so that we can limit our multitasking a bit. I just want to address one thing that has come up on the chat a few times, and then we'll just launch right into this. There was a question about, will you all be able to have access to a copy of our slides? And we will make that available after the presentation's over so that you can go back and look at things and you know, remember some of what we covered. So yes, we will send the PowerPoint slides along after tomorrow. So you can look out for those. We'll send them through Natalia. Okay, so thank you, Corey, for that great introduction. So now we know why CBTP is something that we should be learning about and doing. The next thing that we're going to talk about is what we like to call the spirit of CBTP. And that's really kind of our focus for today in general, because this is an overview. As Corey said, this is just to kind of get everyone hopefully on the same page about why this is important and what CBTP looks like. What is sort of the philosophy and the vibe, so to speak, of CBTP that we want you all to kind of learn and understand and start to maybe be adapting yourselves a bit. Okay, next slide. And because this is an overview, this spirit of CBTP is in many ways one of the most important things we want you to take away from today. There'll be some techniques we talk about, which hopefully will be helpful, but just the idea of what CBTP looks like, how to talk about psychotic symptoms with your clients in a way that is useful and therapeutic and evidence-based. That's kind of what we're going for. Okay, so if we think about cognitive behavioral therapy in general, I imagine that most, if not all of you, have seen the the Cbt Triangle before, right? So that's kind of like the icon or the symbol or the crest of cognitive behavioral therapy. And as you can see here, if we take a look at it for depression and anxiety, and CBT has a very long history and a huge evidence base for depression and anxiety. As you all know, it started out as a treatment for those conditions. And, since then there's been a ton of research for all kinds of other things like addictions and obesity and smoking cessation and obsessive compulsive disorder, so on and so on and so on. But if we think about its origins and sort of a basic cognitive model for depression and anxiety, we see our Cbt triangle to kind of help us along, right? And if we take a look at that, we've got the thoughts, the behaviors, and the emotions or feelings. So if we're thinking about a person who has depression or anxiety, someone in your life or a client that you've worked with, and you think about the kinds of things that they say to themselves or say to you related to their perspective on life for themselves, you hear the kind of things in the top right of the screen, right? I can't function, I can't deal with this, I'm a failure, I'm unlovable. If someone has those kinds of thoughts, if that is the tape that is rolling around in the person's mind, then of course they are going to feel depressed and anxious. It just makes sense. That is how they're going to feel if that's what they're thinking, right? Makes perfect sense. And then, of course, if you are feeling depressed and you have those emotions and those thoughts, that's going to cause you to act or react in a range of really sort of typical depressed and anxious ways, right? So if you have the thought, I'm incompetent and I can't function, then the reaction is this social withdrawal or isolation, avoiding things or tasks that you should be doing in life. And then at the very extreme end of that is suicidal ideation and suicidal behavior. So, the way I like to think about it is this makes so much sense that if a person is thinking this way, then this is how they're going to feel. And this is what they're going to do, right? So you've probably seen this before. That's just a little bit of a review. We can go to the next slide. If we're thinking about how to apply that to some different kinds of symptoms of psychosis, let's take paranoid ideation, for example. In this situation, you've got at the top right some really common thoughts or beliefs that people who have paranoia might have, right? And of course, if they are having these kinds of thoughts, of course they're going to feel worried, anxious, suspicious, and of course paranoid. As a result, if someone is having the constant thought, people cannot be trusted, I'm in serious danger, they're going to avoid certain activities, whether that's going to the grocery store or coming into the clinic to see their doctor or engaging with family members in any way. They're going to be hypervigilant, keeping their shades down at night, all different kinds of behaviors. And you can think about your own clients who have psychosis, who have these kinds of paranoid or delusional sorts of beliefs about safety and threat from others. And they probably at one point or another have said some of these very same thoughts or derivations of them that you find in the top right corner here. And if you think about their reactions and the things that they do or don't do because of those thoughts, you might see some common things you might see some common things there that you see in the left-hand box: the social isolation, the withdrawal, avoiding things that they need to be doing, that hypervigilance, and then safety behaviors, which is kind of like a set of behaviors that a person does that they feel keep them safe, right? In a way, it's sort of like the compulsive behaviors in OCD, right? So the hand washing would keep someone safe from germs or help them, make them believe and kind of quell those anxious thoughts and feelings. Similar with someone with paranoia, if they pull their shades tight and don't open the door, those are considered safety behaviors that reduce the anxiety and help the person feel like they have control over this perceived threat. Now, the problem with safety behaviors, just like in OCD and other kinds of anxiety sorts of conditions, is that it makes things worse, right? Because the person is not taking the chance to learn that they are not actually in danger. And the safety behaviors can kind of grow and grow, and then you've got someone who, won't go outside or won't come to see their therapist. So that's how that works. So you can see that, the cognitive behavioral model for paranoia or voices or delusional beliefs or other kinds of things, negative symptoms, is not terribly different from the sort of quote unquote regular cognitive model for depression, anxiety, and other kinds of really common sorts of conditions. Okay. So if we think specifically about what are our main tenets of CBT for psychosis, and Corey touched on them a little bit earlier on. And, you know, obviously, just like depression, anxiety, eating disorders, smoking behaviors, heavy drinking, whatever the condition is, psychotic symptoms as well are maintained by patterns of thinking and behavior, right? We just saw that in the triangle. And, you know, if we think about someone who hears voices, they may have the belief that they have to do what their voice tells them to do. And if they don't do what their voice tells them to do, they're going to be in some sort of danger, right? So that is their belief or their thought about the experience of hearing voices. Now, if they carry that out and do what the voice tells them to do, maybe the voice tells them not to leave the house and not to say anything to their therapist and not to call their mother back when she calls them, right? So that's the way that listening to that voice and kind of playing into that thought about I have to do what the voices tell me to do will in turn make the voices worse. Worse meaning they might feel louder to the person, they might feel more critical over time, they might be more commanding. So that's an example of the way in which having a psychotic symptom like hearing voices, that kind of thing gets maintained by the pattern of thinking and the reaction that the person has to that symptom in the first place, right? And that's how those symptoms stick around, really get in the way for the person, and oftentimes get worse, right? So we understand psychotic symptoms in that manner, and understanding it that way, and even teaching our clients about it in that way can make a really big difference in terms of adopting the cognitive behavioral model for psychosis. The second thing is something Corey definitely mentioned, which is individuals with psychosis are able to change. Now that sounds like a really simple statement, right? That seems obvious, but as we know historically, that has not been the kind of spirit that people have adopted. And we know that that's not true now, and we know that absolutely people with psychosis, people who have schizophrenia are absolutely able to engage very meaningful in therapy. They're able to examine their own thinking, they're able to examine their own symptoms, whether or not they see themselves as a person who has schizophrenia, whether or not they call their experience psychosis or even use the term voices or paranoia. It actually doesn't really matter if they have that sort of semantic insight into what's going on, as long as they feel distressed and are willing to work on that distress for these kinds of symptoms and problems. They're able to make meaningful changes with the kinds of techniques that we use in CBT for psychosis. So, you know, there used to be sort of this definition of a delusion that it was a belief, a totally 100% false belief held with 100% level of conviction, right? So that's probably what you all learned in your textbooks. That's what I learned about what a delusion is. But what we know over time is that it's not always 100% that a person believes a certain potentially outrageous thought. And you know what? It's not even 100% false, that belief. Often there's what we call kind of this kernel of truth, and we're going to talk a little bit more about that later. That belief came from somewhere. It did not come out of left field. It got kind of morphed and exaggerated over time and became more and more unrealistic, but there is some piece of it that may have been accurate for the person or at the time that they developed it. And so the idea is that, you know, not everything is so ingrained that you can't help a person kind of loosen up about it and sort of change either their thought about it or at least the way they react. And that's kind of one of our main tenets here for CBT for psychosis. The other thing, and this is a related to what I just mentioned a little bit, is that you can really help people make sense of their experiences that they've had in the past that have led up to or contributed to the kinds of psychotic symptoms that they have now. So you can help people make sense of that, and you should and need to. That's a big part of CBT for psychosis, is helping people understand how they got to this place where they have the shades pulled down and they won't leave the house because they're terrified that the FBI is waiting outside their door. What led up in their earlier life to this belief being developed and maintaining itself? And what kinds of things that happened to them in the past can account for the voice that they hear in their head of the person who was involved in a trauma that perhaps that they experienced in their younger years. So, you know, we're CBTP's present focus, but we're trying to understand the context of how these sorts of problems and symptoms and struggles that people with schizophrenia and psychosis have had over the years. So those are some of the main things, the main tenets of CBT for psychosis. Okay, next slide. Okay, so if we're thinking about goals, think about it, and you know, we want you to think about your clients who have psychosis throughout this presentation today. And you know, we are going to be talking about some case studies so that we can all sort of get to know a little bit, but it's important to be thinking about your own caseload and people who you work with or just getting to know through new intakes and so forth who have psychosis and the way their symptoms manifest to better kind of conceptualize and understand what they might be going through. So if we think about the goals of cognitive behavioral therapy, you know, in some ways they're not so different from the goals of any other kind of therapy. Or are they so different from the goals of CBT for other kinds of conditions, right? So what we're understanding is that these kinds of psychotic symptoms exist on a continuum, right? So you've got severe social anxiety, potentially someone who won't go to parties, who won't socialize, who won't even, you know, type an email online. And that's not so far away from light paranoia, right? So those two things are sort of on the same wavelength there. And that's how it is with CBTP too, and the different kinds of goals and things that we would be working on. It's not so far away. It's not so alien, so to speak, from CBT. It's nuanced and there's some special techniques, which is why we're here. But I think it's important to understand that the CBTP is not out of left field. It's within the cognitive behavioral therapy model. So if we think about the kinds of goals that we would have for our clients who have psychosis, I think you know, all of these are important, but to me, number one and number two here are in some ways the most important. There used to be back in the day, and some people still believe this idea that you can't really talk to someone about their delusions or their voices, because if you do, it'll make it worse, right? The person will become more distressed, they'll have to go back to the hospital, et cetera, et cetera. And so it's created sort of this culture of avoidance of really wanting to talk about or delve into the symptoms for clinicians, right? For mental health professionals, which is not helpful. And then also for clients too, who are worried about disclosing any kinds of symptoms like this to their medical professional or their clinicians for fear that they'll get hauled into the hospital again, right? So that's one reason I think why these things have been sort of shrouded. Also, you know, because some of the voices that the person hears can be so critical and terrifying, same with some of the beliefs that a person has that might be delusional in nature, that it just feels, you know, difficult, emotionally difficult to talk about these things, which is of course perfectly understandable. What we want to do in CBTP, though, is help people get comfortable talking about what they are experiencing. And you as a clinician want to be curious, of course, in a non-judgmental way, about what the psychotic symptom looks like to the person. Tell me a little bit about the voice that you hear of your aunt who is deceased. When do you hear that most? What do you notice happens to your body when you hear that? When you smoke pot the night before, does the voice of your deceased aunt get louder or less loud? So it's kind of getting people to kind of wonder a little bit and go, you know, I don't know. I never thought about that. Maybe it gets louder, so that you two can sort of start to have a conversation together about what these symptoms look like and how they're impacting the person. So it's that curiosity and kind of helping people reduce being afraid to talk about sort of the nuts and bolts about that, to really get somewhere. When I say people, I mean clinicians and clients, right? So it's sort of a joint effort. The second piece that I think is really important, sometimes is a bit of a misconception about CBTP, is that we are trying to help the client to decrease their distress about the symptom. We are not necessarily able to decrease the frequency of that symptom or the existence of that symptom per se, right? So a lot of times, you know, people will come to CBTP and say, I want to get rid of the voices. That's why I'm here. Help me get rid of the voices. And, you know, while there's certain things, of course, that can be done to potentially get rid of the voices, and we'll talk about some of those include medication, obviously. That's not necessarily within our power, right? Nor is it necessarily the most therapeutic thing anyway, potentially. So the idea is that what we want to help the person with is the distress they feel when they hear the voice and the way that they manage it when the voice comes in loud and mean, right? How is that impacting their life, and how can we help them deal with it better? So it's decreasing the distress about symptoms, which is sort of similar to this living with illness strategy. So it's this idea of, okay, you hear these voices, you get these really upsetting beliefs, you have a lot of trouble with get up and go, in terms of energy and so forth. This is kind of what you're going through in life. It's unfair, but this is where we're at. How can we help you find ways to live sort of your best life despite those things, right? And that's what we're really talking about with a living with illness strategy. And again, it's helping a person feel like they have some control and hope related to these symptoms, because that's something that we see a lot. You know, think of some of your clients, especially the older ones who have had schizophrenia for many, many years. There's this sense of complete demoralization, helplessness, hopelessness, this idea that, you know, I've had this for a long time, there's nothing that can be done. And you know, we have learned over time that that's not necessarily true. So a person just needs to feel like they have control over what's going on in their lives, or as many aspects of that as is possible, right? And then, of course, the way that we do that is by introducing effective coping strategies. And that's what we're going to be talking about primarily tomorrow. Behavioral kinds of coping strategies that a client hasn't tried yet, or maybe that they've tried but not really given it their all and it deserves another chance, and cognitive coping strategies, meaning cognitive restructuring and skills to help them think or manage their symptoms a little bit better. And obviously, you know, because we are not capable of eliminating voices and delusional beliefs per se, our goal is really to improve a person's day-to-day functioning, to line up with what they want in their lives, whether it's to go back to school or to just be able to walk around the block without feeling terrified, or to be able to have some more structure or relationships in their lives. Whatever that is, we want to help them manage their symptoms better so that they can go and do that. And then obviously from a public health perspective and an individual perspective, we're also doing what we can to prevent an exacerbation of symptoms and prevent relapse and rehospitalization. So those are some CBTP goals. They're very intertwined with each other, as you can see, and it's very important to keep those in mind as you start to really understand how CBTP works and what we're going after. Okay, next slide. Okay, so thinking about what does a CBTP session look like? And we're going to be obviously talking much more about this as we move to introduce our cases, do some demonstrations, and show you some techniques. But I will say that structure in CBT in general, some of you who are CBT trained or have experienced some CBT yourselves know about this, right? That the structure in CBT is key. And that is no different in CBT for psychosis. In fact, in my opinion, and what we know from you know, the way that CBTP is executed, structure is even more important when you're working with someone with psychosis. And here's why. You know, for those of you who have done therapy or who have interacted with people with psychosis, there's a lot of anxiety on board when someone comes in for therapy and has psychotic symptoms. They're worried about what you're going to think of them, what you're going to discover about them, what they're going to disclose to you. There's a lot of anxiety. Oftentimes there's also paranoia about you, about the treatment, about the mental health clinic, etc. And in addition, you've got someone who might be actively hearing voices at the moment that you're working with them, and that's very distracting for them. Obviously, it's hard to concentrate on what a voice is saying and then participate in a session. And similarly, you know, as we know, people with schizophrenia have cognitive impairment in terms of tracking and attention and concentration. So for all of those reasons, a structure is incredibly important. It helps the client know what to expect in that session and across the board, so that there's no curveballs, there's no surprises. When you've got someone who has these kinds of symptoms and challenges, the last thing you want to do is have them come in and feel like everything is just so free-flowing that it's anxiety-provoking. So the structure of CBT in and of itself is highly therapeutic for people with psychosis. In addition, it allows for this collaboration, which is key in CBTP. So, you know, you really are showing the client, hey, we're going to create a structure and organize ourselves together so that you know what to expect, so that we're on the same page about what we're working on, and so that you can contribute and make sure we have on our list, what we want to talk about. And that is key to having a client feel like they want to be engaged with you and have them keep coming back to therapy. So these are the kinds of things that would be included in the structure of a session, and you set the agenda that would include these things with the client. And this is sort of how you basically go step by step throughout a sample session. And obviously that homework piece is important in terms of skill generalization and helping the client be really active in their own treatment. We'll talk more about that as we go on. The one thing that I want to say that's at this bottom part here is so important to help with structure. And this is especially useful for clinicians who are either new clinicians or who are clinicians who may not be used to this kind of CBT structure. It's all about being prepared ahead of time. And now that we're online, it's harder to do that, but it's even potentially more important because you want to create a sense of structure. Obviously, I know I've said that word 15 times, but you want to create a sense of sort of calm and that you know what you're doing in the session. And that really helps assuage anxiety and paranoia in clients that you might be working with. So you've got to be prepared ahead of time. You've got to have your handouts ready, know what you want to be talking about. Keep the agenda manageable. You might only have 25 minutes with the client, depending on what you're doing. Obviously, ideally the sessions are 50 minutes long, but that's not always how it works, right? Especially these days. So you want to keep your agenda manageable. You cannot cover everything, and that's okay. You and the client will kind of prioritize, and you want to keep that thread going through about what you're working on together in CBTP and what phase you're in of CBTP. We're going to talk about the phases in a little bit. The other thing that is so important is to write everything down, right? You want to be taking good notes. You want to be writing out the agenda and sharing it with the client, whether it's on your screen or once we're back in person. And Corey and I listened to, well, I don't know how many we've listened to in our lifetime, but probably thousands of CBTP therapy sessions of different clinicians who are learning the treatment. And the feedback that we often give, especially early on, is write more stuff down. And there's a variety of reasons for that. One is it helps create structure. Two is that it is very hard for people with schizophrenia to sort of track everything that's going on, especially if it's new information, if they can't see it on paper. Even if they don't like to write notes themselves, you as the clinician can provide that. So if we continue to work together with this group down the line, there's been some talk of potentially doing some more consultation and so forth, and you get consultation and feedback from us. I can 99% guarantee that one of the things we'll say as we're helping you learn CBTP is write more stuff down. So that's really important. And it's great for any kind of therapy you're doing, really, even if it's not CBT for psychosis. So that's my pitch for that. Okay. All right, so that sort of gives you a little bit of the philosophy and the spirit. Now we're going to move forward and talk a little bit about our two cases who we're going to track through the next 2 days. Corey's going to introduce our two brief cases.
Thanks, Jen.
Yeah, thank you.
Great. So next slide, I'm going to start by telling you a little bit about Bryant. So Bryant is a 32-year-old. He graduated from college. He's living with his parents in kind of a suburban neighborhood, and he starts experiencing voices. And around the time that he's experiencing voices, he's also getting these kind of like electric shocks in his head kind of feeling. And I'm calling that here as a symptom, a somatic hallucination. Of course, it maybe isn't a hallucination, but the interpretation of it might actually be the part that makes us think that it's more on the psychotic spectrum side, because what he starts to believe is that the neighbor must be interfering with him using wireless technology and some sort of nanotechnology that's implanted in his head and is perhaps is monitoring him and trying to kind of thwart him. So the voices are a problem, but what he's even kind of more struggling with is paranoid thinking, that this neighbor really has it in for him. And he's unemployed at this point, actually probably became somewhat paranoid and delusional at his last job, which was kind of an office-based job. Although he sort of talks about that in the context of people, were jealous of him, or thought his ideas were sort of too good and that they were threatening the people in power, and his supervisors felt threatened by him and his, brilliance, and that's part of why he was fired. But anyway, he's paranoid about that. He's paranoid now about the neighbor, and he's sort of starting to connect the two and starting to think that the neighbor is somehow going to thwart his potential for any future job prospects. He's anxious and depressed because he's home. He's kind of dependent actually on his parents, and that may, it seems like it's gotten worse since the paranoia and the voices. He's isolated. He doesn't really leave the house because this is his next door neighbor that he's most paranoid about. So even like looking out the window is difficult for him. But it is something that he does quite a lot. So even though it causes him stress, he's kind of constantly scanning the environment for anything new or potentially dangerous that might be happening at his neighbor's house. Okay, so if we look at kind of the next slide and just the most basic of conceptualizations, Jen showed you the triangle, and this is like another way of kind of representing the triangle, but it's this idea of doing a kind of very quick case conceptualization using the CBT model. So in this case, we're looking at the person's thoughts, their feelings, and their behaviors in a bit of a different format. So you might think about this as like kind of a miniature thought record, and probably people are familiar with thought records, where you would have the person kind of write down what the situation is that prompted a negative feeling. So the trigger to do a thought record, which is sometimes something that people wonder about, is when you're feeling bad. So when you first notice a bad feeling, that's when you might do a thought record. So in this case, the situation is Monday morning. Well, what typically happens on Monday mornings? People go off to work, people go off to school. What is he doing? He's not able to do those things because he doesn't have those roles. What starts kind of happening in his head? And sometimes we think about a voice or a thought as sort of the same thing, because essentially we'll talk more about what is the model of auditory hallucinations, but auditory hallucinations have something to do with a person's own thinking, right? So he hears this voice, "We are going to ruin your career." And his thought that's associated with that is, "I will never succeed." How does he feel? He feels sad, he feels worried. Maybe he's also having these experiences in his head, these somatic sensations in his head, which could also be captured here under feelings. And what does he do? Well, what he does is he talks to his dad and tells him what's going on and that he needs to believe him. And now, interestingly, in this particular case, the dad actually was sort of on board with him initially in not liking this neighbor. So this neighbor, they were sort of thinking that this neighbor was kind of lowering the standards of the neighborhood, was having parties, was bringing in kind of the wrong element of person. So they were allied. The family was all kind of on the same page about this neighbor at one point. And this kind of, gets to a little bit what Jen was saying before about the kernel of truth. So there was a time when people thought this neighbor was kind of a bad actor. But now he has kind of elaborated this to now thinking that there's all kinds of things going on that people don't agree with. So you can imagine what happens with this behavior. He talks to the dad and they get into this big argument, right? That, this isn't going on, something's wrong with you. We might need to put you in the hospital. Are you taking your medicine? There's all kinds of stuff that unravels around this, right? Which you can think about as feeding back to the distress versus actually solving the problem and getting him to feeling better. So in CBT, you probably are also kind of aware of this idea of like core beliefs or like bigger beliefs that organize ideas about the self, the world, about others. That's what this box is underneath, is sort of what are the core ideas that he might hold at times that are giving rise to these negative automatic thoughts and the way he's interpreting. So kind of like the glasses he puts on, like what's his lens, the way he's looking at the world. And he does think about himself as, at this point, a failure, unfortunately. And he also has, which is not uncommon actually among people who have anxiety, is this idea of competition, that kind of life is a social hierarchy. And that, everyone is sort of out to best someone else. Like we can't all do well. Someone has to do well and someone has to fail. And he's sort of a subscriber to that kind of philosophy. And when, you could even look back a little bit more and think a little bit about some of the early experiences he had in life. And also, as Jen mentioned before, CBT does tend to be present-centered, but it doesn't mean that our learning in life wasn't influenced by something that happened in the past. So it's completely reasonable to go back in time a little bit and learn a bit about this person and who is he and what's kind of, what influences may have given rise to some of these core beliefs and to even these current experiences that he's having now. And this is a guy who was a very, very straight arrow, really by the book, rule-bound kind of guy. And he didn't have a lot of friends, perhaps because he was sort of more of a like mini adult kind of kid. And then there was also this climate about like appearances being very important in this family, which is why this neighbor made such a splash in all of their lives. Like, why was it such a, for some families, it's not a big deal, right? What happens, who your neighbor is. But for some families, it's a really big deal because it's a reflection on them. And for them, this was a very hard thing to tolerate, that this person moved in and was not, subscribing to the cultural standards that they thought the neighborhood should have. So that's just a quick formulation, okay? And if we go to the next slide, what we're trying to do here is just give you a nugget. So we're going to talk more about, aspects of Brian's treatment, but this is kind of like it's like the reveal before we dive in. This is the kind of short, Cliff Notes version of what happened in this guy's treatment. How do we think about him? So, not surprisingly, what did we do? Well, we worked on, better strategies for dealing with the hallucinatory experiences and the somatic experiences, understanding more about his symptoms. We actually did some collaborative research around wireless technology. This also kind of relates to what Jen was saying before. I think when I first started working actually in a clinic that was a community mental health center, one of the things I noticed when I took over cases was that the clinicians were often charting, patient didn't talk about delusional material today at all, and seeing that as a good thing. And I think that's where we're very different in CBT. We're not, you can reinforce all kinds of things with people, right? You can reinforce people not to talk about something, but does that mean they're going to get better? Not necessarily, right? So we're actually wanting people to talk about this, but maybe to talk about it in a different way. To get a little bit more curious rather than kind of the same dynamic that you often see playing out. So in this case, the dynamic that was playing out a lot in this family was, Dad, you have to believe me. There's wireless technology. I know it's happening. And then Dad saying, you're crazy. This is not happening. You need to, we need to call your doctor. Okay. The other thing that, we start to do in CBT is we form hypotheses together with the client about what's going to make this better. So if part of our case formulation in this case is that feelings of failure, and perhaps those feelings of failure are being maintained by low productivity and a low sense of being, valuable and valued in the world, if we increase the sense of feeling valued and productive, some of this should fall away. Some of this should decrease, right? So we kind of look at this and we study it together. We make the person a collaborative scientist with us. So what happens if you get more productive? How do you start to feel about yourself? What happens to the voices? Are they as distressing? Are they as insistent? Are they as distracting, etc.? And then, there's always a focus on functioning too, not just symptoms, because recovery in, illnesses like schizophrenia isn't just about getting rid of symptoms. It's about living a good life and living a rich life. And so for this guy, he really needed a path to career. And so getting connected to a supported employment specialist who could really help him in a concrete way and tangible way to move forward was also extremely important. So that's just a snapshot of Brian, and we'll be talking more about Brian. I'm going to move on now to talk about a second case. And this is a case where, again, there's paranoia and voices, but the voices are very clearly the key problem for this woman. So this is Charlotte. She's 60. She lives independently in Section 8 housing in her own apartment. She has a lot of family nearby. She lives in kind of a middle-class neighborhood. She's hearing voices very often, mostly in her apartment, but also when she's outside. She connects these voices. The voices say really mean things. They're derogatory. They reference her schizophrenia. She thinks that they might be connected to the police and perhaps the FBI, and that they're keeping tabs on her and monitoring her. They give her a lot of commands and instructions. She changes her life quite a lot in response to what the voices tell her to do. So for example, the voices will say things like, she's so loud up there. She's, and they'll allude to her weight and things like that. And so she'll take her shoes off. She won't walk in her apartment with shoes. She won't walk sometimes. She won't turn on the water because she doesn't want to kind of upset the voices. So there's a lot of placating and kind of, trying not to make the voices angry. She also, she kind of likes the voices in some ways, and this is not that uncommon actually. So I mentioned in the beginning that CBT is really more effective for people who have some distress related to the voices. Oftentimes, just because someone has some pleasant aspects of the voices doesn't mean they also don't have distress. I remember doing a study very early on with people with voices where we asked people, would you miss the voices if they were gone? And about 40% of people said yes. These were frequent voice hearers. So voices, serve a function for people too, and we'll talk more about that later. But in any event, so she sort of thought that, she was connected to the FBI. She was kind of important enough to be watched by the FBI. She thought the reason for this was that she had established a really important connection in her 20s. To her, it was very important connection to the firemen and policemen in her town. She was sort of a little bit wild and was doing things to get in trouble from time to time. And they kind of took her under their wing as like a mascot. So she'd kind of hang out around the fire station and the police station. And she felt very cared for by these mostly guys, I guess, at that time. But in any event, she, we always talk about that, right? That the flip side of kind of paranoia is grandiosity. I mean, in order to be tracked, you kind of have to be important enough to be tracked. And there was a little bit of that with her. She, sometimes though, like I mentioned, wouldn't take good care of herself because the voices would tell her not to shower, for example. So she just wouldn't shower, or she'd shower with her clothes on or something like that because she was feeling watched. She just wasn't living her own life. She was living the life that the voices told her to live in a lot of places. Okay, next slide. So how do we conceptualize her? And I've already alluded to a bunch of these things, but so what kind of thought record might we get from her? Well, she's home at night. She has the thought that the neighbors' voices are going to bother her, and she thinks that the FBI is monitoring her. She feels sad. She goes to bed at 4 p.m. And this is a going to bed at 4 p.m. just to not have to deal with the voices. The voices for her are much worse at night. It's not uncommon that people experience worse voices at night. What does she think about herself? She feels vulnerable. She feels taken advantage of. She feels unlovable. So, I think the unlovability schema and the incompetence schema are two key schemas that Beck identified, right, in cognitive therapy for depression. And we're sort of exemplifying them here with Bryant kind of being the incompetent failure side and Charlotte thinking about the unlovability side. And then some of these life experiences I sort of talked about already that might have had something to do with, some of her beliefs about being connected to the FBI and the police. And she did have a sexual trauma when she was in her 20s, which may be another influencing factor, since trauma is a risk factor for all kinds of mental health conditions, including the symptom of hearing voices. Okay, so next slide. So what did her treatment look like in a nutshell? So again, and you're seeing the simplicity really here of what we do in cognitive behavioral therapy for psychosis. There's a lot of similarities. We try to help people understand their symptoms. Now, each person needs to understand their symptoms from their own personal context, which is what makes it different. Although there is some standards like psychoeducation that we just do with everyone. Decreasing her safety behaviors and her fear and her avoidance, right? So what she's doing with the voices is her main strategy is to comply or to avoid or to shut herself down. And so we might want to move her in a different direction, a direction of reclaiming her own life, or of compromising with the voices, or something different than what she's doing, right? And then, you know, the other part, again, kind of like before when we were talking about the core belief, if our hypothesis is that part of the function that the voices are serving for her is to create a bit of a social world and social connection and a feeling of being cared about, what happens if we try to increase that feeling of being cared about by others, people who are actually in her life? Because this is not a completely socially isolated person. She has actually a friend or two. She has family right around her. And it may be more a matter of actually attending to the care she's getting versus attending to all the ways that people are letting her down, right? Because once you start doing that, it's a recipe for, you know, being pretty certain to be disappointed. So that's the kind of thing we did with her. And you'll hear much more about her. So actually what we're going to do at this point is we're going to transition to a bit of a trainer demonstration. So Jen and I are going to do a trainer demonstration in which one of us is going to play Charlotte, I think. Yeah, I'm going to play Charlotte, and Jen is going to play the therapist. And what we're going to talk about actually is how to introduce CBTP. And the reason for this is actually a key therapist skill. It's essential that you have your spiel. You need to know how to introduce this to people. You know, one of my colleagues, she calls it, you know, you're selling something. You're not just, you know, people aren't educated consumers about therapy. So you have to decide, how are you going to make this, you know, sound appealing to someone, and also give them an accurate expectation about what this is going to be like. And so what we're going to demonstrate is how Jen as a therapist might introduce to Charlotte, what is CBT for psychosis, and why is it something you might want to do?
Oh, can we just go back to the previous slide? Perfect, thanks. Okay, so I'll just set this up a little bit. This is just going to be a couple minutes long. Corey's going to play Charlotte, as she said. So keep in mind some of the things we just talked about with Charlotte. I'm going to play the therapist. And this is just a little snippet of how you might go about this. And in a way, at first I was going to say suspend disbelief and pretend we're in the same room live with all of you all doing this, because that's how we usually do our demonstrations, like we're sitting in a therapy room together. But you actually don't really have to suspend disbelief, because this could be very well the way that you are introducing CBTP to a new client, right, over Zoom, if that's the kind of technology you all are using with any of your remote work. So hopefully it's helpful thinking about it, both if you are in person with a client, and also if you were, you know, far away from them remote. The other thing is, the way we're demonstrating it is that this is Charlotte's sort of a new client, right? Maybe there's been a session or two, an intake. Maybe she's been part of the clinic and was just referred for CBTP. This is not a client who I, for example, since I'm the therapist, had been working with for 12 years, and now I'm transitioning over to CBTP. That's not to say you can't do that. We've supervised a lot of cases where that has happened. It's a little more challenging, as you might imagine, because you've sort of developed this kind of pattern with some of the more long-term clients who you might work with, and sort of a way of doing things, and it can be a little jarring to make that shift, but it is possible. But you know, ideally, you're sort of introducing CBTP in this way to a client who's new to you, whether or not they've been in the clinic for a really long time. That's understandable and perfectly fine. So just kind of keep that in mind as we go through. Okay, should we get started? Okay.
Sure.
All right. So Charlotte, you know, we decided today that we'd meet, and I tell you a little bit about the kind of therapy that I do. Does that still feel okay to you?
Yeah, sure.
Okay, well, let me just tell you a little bit about it. So I think we had talked before that this kind of therapy is called CBT, right? And it means cognitive behavioral therapy. And I'm writing, you know, I can write that down on a piece of paper for you if that helps. And cognitive just means thinking, or the way that we think about things. And behavioral is kind of the stuff we do or don't do, right? And so CBT is geared toward helping all kinds of people with all kinds of things that they're struggling with. So like CBT can be used to help people who have depression, who have anxiety, who are having trouble with drinking or using drugs a lot, people who are having trouble quitting smoking, having trouble eating right or nutrition, people who are really worried about other people, that kind of a thing. So that's kind of the sort of thing that CBT can help you with. And I want to tell you a little bit more about it and how I think it might be a good fit for you, if that's okay too.
Yeah, okay.
Okay. So, what CBT focuses on is this idea that when we're distressed about something, when we're really upset about something, our brain can kind of just get into these patterns of thinking and behaving that are totally understandable, but may not be working to actually help us reduce feeling upset, right? In fact, they might be keeping us upset or making us feel even worse, right? So I see you kind of nodding your head. Is that sort of something that you've experienced before? Like the way that you think about something keeps you upset?
Yeah, like I think I'm just not like handling things well.
Mm-hmm. And my sense about you, Charlotte, is that you are doing the best that you can do, right? And that is so important. And at the same time, you may be right that maybe there might be a better way to be, thinking about working on some of the stuff that's been hard for you.
Mm-hmm.
Let's take an example, just so we're on the same page about, sort of how thinking and feeling upset might work together. So like, if someone's really upset or distressed, what's a common thing that they might do if their family calls them or stops by and knocks on the door? What might they do if that happens, if they're like really, really distressed?
Yeah, like I might pretend I'm not home. And
Okay,
like
right.
not answer the door.
Right. Yeah, that makes sense. Exactly. Right. So if that's what you're doing, right, if you're really upset and your family comes to the door and you just pretend you're not there and don't open it, what might you or that person be thinking? What might be going through your head when your family visits in that situation? Like what might,
Well, I just think they think like I'm a burden, and I think that they're just like feeling sorry for me or something. But like if they hadn't been there, they didn't come by like the whole rest of the week, and I'm like mad they weren't there for me, and so I feel like they're just all of a sudden feeling sorry for me or something.
Got it. Right. So that's such a great example, Charlotte. So sometimes we have a bunch of different thoughts that go through our head about a situation that happens and it makes us really upset. So one of the things I'm hearing is that, well, they didn't come by all week, right? So having that thought made you feel angry, right? And then the other thought that you're having is, well, they just feel sorry for me. That's why they're coming by. They don't really, want to spend time with me. And those are the kinds of thoughts that would kind of propel you or make you decide to not answer the door, right? So that's a way in which your thoughts can kind of impact what you choose to do or how you choose to handle a situation. And that kind of thing, right? That's situation that we just described, which is really common, right? Might actually make that depression or sadness sort of stick around, right? And maybe even get worse than it was before. So, one of the things that we do in this therapy is kind of examine that a little bit and see if the way out of something like depression feelings or sadness might be to come up with other ways of thinking about things or choosing a different way to react when something happens to make it so that you don't feel quite as sad. Does that make sense?
Yeah, yeah, it does.
It does. Okay, good. Yeah. And so one of my specialties with CBT is helping people with some of the kinds of specific experiences that they have had that may be causing problems in their life or maybe kind of keeping them stuck or not moving forward in what they want in life. Like some of the stuff that you mentioned a little earlier today or in our intake last week, which was like hearing the neighbors' voices, right? That those are the kinds of experiences and that a lot of people have, and that in CBT we can kind of examine a little more and see how to help you cope with it. Try to work on ways to respond to those voices to help you feel less distressed.
Mm-hmm.
How does that sound to you, Charlotte?
Yeah, so like you've seen other people like me who have this.
Yes, absolutely. A lot of other people. I know, obviously we're all unique people and no one has the same experience, but it's actually more common than we think, or that we used to think, that people hear things that maybe other people don't hear, and that those things that they hear can really, really get in the way and really make us stuck and make us feel really pretty awful. So that's actually, fairly common, actually.
Wow.
Well, so let me tell you a little bit more about sort of the nuts and bolts of this therapy and how it might work. So the other thing about CBT that might feel a little bit different than some other kinds of treatment you may have done in the past, is that we will do our best to kind of keep our meetings pretty organized. So what I mean by that is that each week when we meet, we'll have an allotted meeting time, as much as possible. We'll try to meet every week. So we'll usually start off each appointment we have, kind of remembering what we talked about in our last appointment. And then we'll make up a list together of the important topics that we want to make sure we cover in the time that we have that day, right? And we'll both contribute to the list. I'll come in with things that I think would be helpful or important for us to work on, and you'll come in and maybe add something to the list that happened this past week, that past week that you might want to make sure we talk about, and we'll work on it together. And the purpose of that is not to be, sort of robots or machines and not human beings, but it's instead to make sure that we both know what to expect, right, before we start our session. So it doesn't feel like there's curveballs or surprises. So we have a plan, and we make sure that that plan is something that works for me in terms of what I'm trying to help you with, and works for you in terms of you feeling like you're getting your needs met in the session. And it will also help us make sure we kind of prioritize and get to all the important stuff each time, so that we, and especially you, Charlotte, can kind of feel like we made some progress after each meeting. So you'll walk out of each meeting and go, okay, we're moving forward a little bit. And I can tell you some other things that are specific or unique to CBT, but let me pause here and see if you have any questions about anything I've told you about, or anything else you might be wondering about.
Yeah. Well, I mean, I'm just like a little bit not sure about going way into my past and stuff. Like there's some stuff really bad stuff happened to me. I don't like to talk about it. And like writing things down makes me nervous because I wonder who's going to see it. And, like, I don't know if I have to write stuff down, does it go into like my record, or how does that work?
Yes. Charlotte, I'm so glad you shared those concerns with me. That is so important, and this is the perfect time to do that. So let's talk through that a little bit. So I completely understand not wanting to delve too deeply into the past, especially, if there were some really painful things or scary things that happened a long time ago. So the first thing I want to say is that CBT is very present focused. That means that we will be primarily working on the day-to-day stuff, the things that are happening now that we want to help improve in your life, right? That said, though, sometimes it might be important for me to know some things that happened before, so that I can kind of understand where you're coming from, right? And so that I can help you better understand how those kinds of things that may have happened in the past played whatever role they played in some of the things that you might be struggling with now, right? And so all of that said, though, we won't have to go into a ton of detail about those kinds of things if and when we talk about them. It'll just be so that I can kind of understand kind of what made you you, right? And some of the things that impacted, what you might be going through now, and how to help you move forward, right? And you absolutely only have to share with me what you feel comfortable sharing.
Okay.
What do you make of that? How does that part sound to you?
Yeah, I guess I'm glad to hear you say that, because the voices really tell me not to write things down, or like not to talk about them. So I'm really like hesitant to do that, because they're just like might, kind of retaliate.
Mm-hmm. Yes. And I'm glad you shared that piece too. And that's that, it's actually common to feel that way. People who hear voices are worried about, how to sort of act or react, especially if they're talking about the voices, and, people are concerned about keeping records and so forth. And I totally understand that. what I would suggest is that why don't we first spend some time kind of getting to know each other, figuring out a little bit more about when the voices feel the meanest or the most intrusive to you. And that can be our focus as we start off. And then, you know, as we go, we'll see how it's going. We'll try to make some decisions together from there. But again, you know, it will always be entirely up to you how much you want to share and how much or what you want to write down. And I'll be here to kind of support you along the way.
Okay, that sounds good.
Okay. All right. So we're gonna end that demo now. Hopefully that felt oops, sorry, I just clicked the Q&A by accident. Hopefully that felt like a nice way to a good sort of broad brushstroke of an introduction for, you know, how to go forward with introducing CBTP. We can talk about, you know, reactions or questions to that after the break. If you have one, you can type it in and we'll address that after the break, which will be coming up in a little bit. We have a little bit more to cover and then we'll go on break. Corey, anything you want to say about the demo before we go forward to our next topic?
No, I think we're good.
Okay. Okay. I'm going to jump in here and talk a little bit about how to understand and conceptualize psychotic symptoms. We talked a little bit about this in the beginning of our day in a sort of broad way, but we want to delve a little bit more into this because this is the key to understanding CBT for psychosis, is how do we think about in CBTP, in the cognitive model, the kinds of struggles and problems that someone with schizophrenia has. And the way that we think about it and understand it and conceptualize it is what guides and drives the specific kinds of techniques that we do, right? So we're not choosing techniques just blindly, where they are based on what we know from science about how people with schizophrenia think and feel and react and kind of go through their world. So I'm going to be talking about these cognitive and perceptual underpinnings. And what we mean by that is these sort of thought processes that research has found in terms of how a person with schizophrenia thinks in a broad way. Same with their perceptions, right? Meaning the way that they like literally see the world. And we'll talk more about what that means. So this is kind of a key thing for your sort of foundation in terms of understanding CBT for psychosis. Okay, next slide, please. Okay, so many of you, if not most of you, if not all of you, have probably heard of or seen the stress vulnerability model, right? So this is the idea of how psychiatric conditions kind of come to be, right? And it's not just psychosis per se with the stress vulnerability model. It's a model for sort of many, if not all, of psychiatric conditions as we know them, right? So if we think about the stress vulnerability model, we know that there's that biological vulnerability that can be genetic or neurobiological in nature. And then there's the stress, which is if the person has that kind of biological vulnerability, and then they have sort of a stressful event or a series of stressful events or a traumatic event or some big thing, oftentimes that's what sort of catapults them into the emergence of whatever symptoms are coming out for whatever condition they have, right? So hopefully that idea feels familiar. And, you know, there's a lot of overlap in terms of the way that the biological vulnerability and the stress intersect with each other. So let me kind of just walk you through this picture here. Some of it is pretty straightforward, but if we think about schizophrenia, the development of schizophrenia, the maintenance of the psychotic symptoms, excuse me, what makes psychotic symptoms emerge in the first place, what causes a relapse for psychotic symptoms, or what makes psychotic symptoms better or more manageable. A lot of stuff is on this page right here, right? So let's think about it. So what we know in terms of the biological vulnerability piece is that medication plays a role, right? In terms of kind of reducing the impact of that biological vulnerability, right? Now, as we talked about earlier, medication doesn't 100% work for every person, nor does it, you know, completely take away the psychotic symptoms, but it helps for sure most of the time. And that is a way to impact the consequences of the biological vulnerability, right? So voices, conceptual disorganization, those kinds of symptoms can be impacted positively by medication, right? Notwithstanding the physical side effects, that's different. But the other thing to be thinking about in terms of what can impact or have consequences on biological expression of schizophrenia is substance use, right? So we know like a family history of substance use can make a big difference in terms of what a person ends up developing. We know that substance use in someone who has schizophrenia already worsens their schizophrenia, right? We know that someone with schizophrenia or the emergence of psychotic symptoms has a higher propensity to use substances. So really, in a way, that should be kind of like a double arrow for thinking about pathways of one thing that leads to the other sometimes. In addition, there's something at the bottom there called cognitive vulnerability. And that's some of what we're going to talk about in the next few minutes. It's this idea that people who have schizophrenia or who are at risk for schizophrenia or psychosis have a certain way of thinking about things and perceiving things that makes them more vulnerable to either developing those symptoms or having those symptoms be maintained or made worse. And we're going to look at a couple of examples of that. And so you can see really, it's not just your biological vulnerability and that stress that's going to cause you to have a relapse and a rehospitalization and really struggle with your day-to-day functioning. It's also the way that you're perceiving it. So if we think about something that causes a relapse for someone, a lot of times the model is, you know, excessive drinking, and, you know, the biological vulnerability of having had an episode of psychosis before, and, you know, a stressful event, and then the arrow goes to rehospitalization, relapse and rehospitalization. And what we want everyone to be thinking about is the role in which a person's beliefs about what's going on with them at that time might play a role in whether they end up having a relapse or not. So if the thought is, oh my God, the voices got louder, that means that like I'm sunk and I'm definitely going back to the hospital. Might as well, you know, drink for the next few days before that happens. That kind of belief is obviously not going to stave off a relapse. It's going to catapult the person forward. So it's important to be thinking about kind of that cognitive vulnerability or those sorts of beliefs that intersect with the psychiatric symptoms of schizophrenia and that stress piece. Okay, so hopefully this picture is becoming a little clearer. At the top here, we've got the things that tend to reduce stress or make stress more palatable for people who have schizophrenia or who have had an episode of psychosis. One of those is coping skills, right? But not just any old coping skills. We're talking coping skills that work, that the person is willing to try and that actually make a difference. So we're going to teach you some of those today. And I'm sure that you know some really good ones too for your clients with schizophrenia, often to be individualized to the person, depending on, you know, what works for them. But there are some specific coping skills that we know universally from the evidence, the research evidence that do work. Then of course, social support, meaningful social support, have, you know, in terms of treaters and family members or neighbors or just, you know, friends, a community, a fellow therapy group members, etc. And meaningful activity, right? So Corey talked about that with Bryant, about not having that structure, that meaningful activity, making things worse for him in terms of psychotic symptoms, right? So it's like you want to have those things on the top, and all of those things can stave off stress a bit. So that's a way to conceptualize kind of the regular stress vulnerability model and apply it to psychosis, taking into account the thought processes that people with schizophrenia might have that might make them more vulnerable to having an exacerbation of psychotic symptoms, but also as a place where you can sort of tweak or make some inroads or changes to reduce the risk of having a relapse and being able to stave off that kind of stress. Okay, so hopefully that feels like it's a helpful conceptualization. So that's our first picture. This is going to be sort of, this next part is sort of like a series of pictures and graphs that I will be explaining to you. Next slide, please. Okay, so one of the things that studies have shown that people with schizophrenia tend to have is what we call a selective attention bias, right? So you may have heard that term before. Maybe your spouse has that. Maybe your teenage children have it. It's this idea of paying attention to certain things and ignoring others, right? So, you know, I make a little bit of a joke that I think in the vernacular, we tend to use selective attention bias as something that's like voluntary, like, you know, if someone doesn't feel like paying attention to, you know, an instruction you give, we call that selective attention bias. But as we think about it in terms of psychosis or schizophrenia, it's actually a real sort of, I don't want to say condition, it's not a diagnosis, but it is a phenomenon, a cognitive phenomenon that studies have shown that people with schizophrenia have and enact, even if they're not trying to, right? So here's just a little example of what that might look like. So picture a client of yours who has, you know, schizophrenia and a propensity for paranoid thinking, walks into a convenience store, right? So there's a couple of things that happen when the person walks into a convenience store. Maybe he walks in and sees a shopkeeper there and asks a question about where his favorite kind of cereal is, and, you know, perceives that the shopkeeper, you know, doesn't give him a smile and a nod, doesn't walk him over to where it is, just, you know, says, "I'll too," and just then kind of walks away. So that happens when the person walks in, right? So with selective attention bias, what tends to happen with this sort of client is they take that interaction, and even though that interaction maybe was kind of neutral, like maybe he just, you know, the shopkeeper just gave a pretty basic answer, if the person has schizophrenia and a tendency towards, you know, delusional or paranoid beliefs, that client will sort of imbue in that this sort of negative interaction, which sort of sets the stage for selective attention bias to kind of kick in, right? So from there, he might start to notice certain things that go on during his experience in this convenience store and not notice others. So the stuff in the green is the stuff that this person starts really paying attention to. There's when he was walking into the convenience store, there happened to be a policeman standing outside, and that policeman was not smiling. So he thinks about that. And then there was a guy in a black leather jacket that was also in the convenience store, in the soda section by the soda cooler, and he thinks about that guy. Then all of a sudden, he kind of pulls all this together and is paying very hard attention to those things, and his underlying belief, or his frequently common paranoid belief of other people want to hurt me, gets kind of triggered or enacted, and he gets very anxious and very paranoid in the store, right? So that's kind of how that happens. However, because of selective attention bias, this client is only paying attention to the stuff in green, right? But what about the stuff in blue? That also happened while the person was in the convenience store. So for example, when he was walking down the aisle, a woman smiled and said hi to him. A guy opened the door and held it for him when he was coming in. And the cashier, when he checked out and bought his cereal, gave him a couple extra pennies with his change, because, you know, she kind of said, "Oh, I'll just take it." And so those are some neutral or positive things, but those get weeded out in people who have paranoia and these kinds of delusional beliefs in the service, instead of focusing on these sort of neutral or maybe slightly negative things, who knows, and all of that triggers that belief of other people want to hurt me, or whatever the paranoid kind of belief is that the person might have. So that's kind of what we call a cognitive and perceptual underpinning. It's a way that a person thinks and perceives things that maintains or worsens the psychotic symptoms. Okay, next slide. Let's take a look at the next thing. Okay, so this is a big one, as you can see. There's a lot here, and, you know, we're not going to spend a ton of time on this, because we could do a whole 2 days about this kind of conceptual framework, and it's fascinating. It really is. But I'm just going to try to, you know, make sense of it for you fairly quickly, and you know, kind of do a summary. So this schematic is courtesy of our friend and colleague, Dr. David Penn at UNC, who's done a lot of research and a lot of studies on this kind of a thing. So we call this social cognition, or the way that a person, particularly with schizophrenia, might have some impairments or challenges in terms of the way that they perceive interactions with other people, right? So if you've got someone with paranoia or delusions, we do see these kinds of impairments or challenges in social cognition and social functioning. So let's kind of walk through this. Okay, so this particular client has a job and goes into work and sees this guy in the photo here who is his coworker. Takes a look at that guy and immediately thinks, oh, my coworker's angry. Why does he immediately think that? So there's a couple of things to consider that are kind of going on in the background, right? Or deep in the brain, so to speak. And one of them is emotional perception. So I don't want to get too much into this because there's a lot of, sort of sciencey research, but what studies have found is that people with paranoia, delusions, schizophrenia have deficits in terms of visual scanning. So when you are looking at a person or looking at their face, we tend to take in sort of all aspects of that person's face and all their expressions and sort of see the sort of gestalt, so to speak, whole picture. There is an impairment that exists that people with schizophrenia or people with paranoia and delusions don't do that as much, right? So they might focus on some little part of the person's face, but not kind of get the whole picture, right? It's sort of a narrow focus. And then also sort of tending to perceive people's faces who are showing neutral emotions, that they are showing negative emotions, which isn't actually necessarily the case. So from like an emotion perspective, perception perspective, we're in a situation where this client looks at this guy and thinks, oh, my coworker's angry, right? Because of some of those visual scanning deficits that studies have shown that people with paranoia and delusions have, right? So that's one reason why he gets to that place. The other thing that you can see where it says jumping to conclusions and need for closure, there's been a variety of other really neat studies done where people with paranoia and delusions tend to jump to conclusions faster and more strongly than people who do not have paranoia and delusions, right? That kind of makes sense. And they've done this study with a variety of kind of like basic experimental tasks that have nothing to do with the client's personal life or really have nothing to do with other people, and have found that people with paranoia and delusions want to kind of come to a conclusion as fast as possible and will come to that conclusion and stick with it even in the face of other evidence, okay? We also call that concept the need for closure, meaning that people with schizophrenia have this sort of need to get to an answer and kind of shut it down. And it can be any answer as long as they are able to sort of get to that answer, which provides an initial sort of sense of relief. Okay, so as you can hopefully start to clue in here about is that these are the kinds of underpinnings or underlying things that would cause this particular client to walk into work, see that guy's face, that coworker, and go, oh, okay, my coworker is angry, right? Jumping to that conclusion based on these things. The second piece is attributional style. And some of you may have heard about this in terms, from like psychology textbooks early on, social psychology, things like that. It's really interesting stuff, but it's this idea that we attribute certain kinds of things that happen to ourselves, like our own control or our own behavior or doing, and certain things that happen are sort of outside of our control or attributed to other people or the world or just kind of happenstance or luck, right? So that's sort of the idea of attributional style. Now, again, people with paranoia and delusions tend to have a bias with this, so that they would tend to attribute behavior that's outside of them and personalize it, right? Make it about themselves, so to speak. So for example, in this situation, not only does the client first come to the conclusion, well, gosh, my coworker's angry. The second piece of it is, oh, well, if my coworker's angry, he must be angry with me, right? That's that personalizing bias, that exaggerated personalizing bias that people with paranoia and delusions have. There's also something called theory of mind, which is a whole other fascinating thing, but it's kind of this idea that people with paranoia and delusions tend to have difficulty putting themselves in other people's shoes, right? That's sort of the basic way to understand it. So the idea is that this client would not stop to think or not necessarily be able to conceptualize why this client might possibly have the look on his face that he does, or if he actually is in fact angry, why this coworker might actually be angry. So it's hard for a person with paranoia and delusions to sort of abstractly go, okay, well, maybe he has that look on his face because I just know he was looking down at the clipboard of the deliveries that were supposed to happen today. Maybe he seemed confused. Maybe he was confused by that, right? That's why he kind of has that like scrunched eyebrow, right? A person with paranoia and delusions has been shown to not really be able to take that step, right? Nor would they be able to take the step of, well, if he is angry, you know, maybe he just had an argument with his partner, or maybe, you know, his coffee tasted bad. There's just that piece where the person just can't step into another person's shoes, right? So now we're at the point where this client's in a situation where he's at work, he decides his coworker is angry, his coworker is angry with him, and he's very rigid about that and kind of clings to that conclusion. Now, what does the client do if he believes that the coworker is angry with him? Well, because he sort of has that paranoia triggered and that fear and that upset, he kind of distances himself from the coworker, acts kind of unfriendly, and then maybe it becomes a whole thing, right? You can sort of foresee how for this particular client, maybe he's had trouble holding jobs before, and he's gotten this job in this factory for deliveries, and it's sort of his fifth chance. But similar to what's happened in the past, there's been sort of this social cognition deficits that have created situations that have escalated where this guy, you know, ends up quitting or not showing up for work because he's so paranoid, or getting let go, right, for, you know, some inappropriate behavior towards colleagues. Anyway, all of this is to say that something as simple as interacting with a coworker has all this stuff beneath it that science and great research has taught us that people with schizophrenia and psychosis encounter. So again, this is not, you know, this is a complex picture here, and it's not to sort of memorize, but it's just to help you kind of understand how this works. And, you know, depending on who you're working with in certain situations, you might actually explain some of this to your clients who you're working with as you're teaching them what CBTP is, as you're introducing this idea to them, as you're helping them kind of work out if they have some kind of really negative, what they perceive as a negative interaction with a coworker or a group member or a mental health professional or whatever. There might be some opportunities to share a little bit of this piecemeal and in simplified terms to the client themselves. And that's kind of what, you know, a piece of what we call psychoeducation, right? It's also a way to help the client make sense of what their experiences are. And as you'll recall from earlier today, that's one of the things that we are trying to do in CBTP. Acknowledge the idea that clients need to make sense of what they experienced today. They need to make sense of their psychotic symptoms, and we need to help them do that through a variety of ways. And this is just one of those ways for you as a clinician to more deeply understand this, so that you can teach skills to your clients, but also so you can maybe teach them a little bit about this here and there. I wouldn't show them this chart. It's a little much. It's a little much for me, and even, but you know, it's something to be thinking about. Okay, next slide. Thank you. Okay, so then we're going to do a little exercise now. If everyone could open up their chat. This is Corey and I, as you can hopefully tell, from a few years ago. We're a little older now. And as you can see, we're sitting somewhere and we have a giant pile of money in front of us. One of the things that, you know, you're probably deducing about what CBTP does in terms of these, you know, underpinnings and helping clients understand and broaden their experience and become more cognitively flexible is to help them reduce that tendency to jump to conclusions. Oh, my coworker's angry. Oh, my coworker's angry with me, and then sort of retaliate. We want to slow down that process. And one of the ways we do that is by trying to help them sort of think outside the box and broaden their descriptions or perceptions about what could be happening in any given situation. And we're going to teach you some techniques tomorrow called alternative explanations about how to do this. But this is just a way to kind of get those juices flowing a little bit. So here, Corey and I are with a giant pile of money in front of us. What could be happening in this photo? Okay, so we've got some possibilities up here. And if you could just kind of open your chat up and type in some other things that might be happening. And the purpose of this is, you know, just for us to take a little fun break together, but also to help people kind of get a sense about what we're asking our clients to do in terms of cognitive flexibility, thinking outside the box, getting your brain working, generating some alternatives that may or may not be the right alternatives or the right answer. We're not necessarily trying to get to the right answer, but instead we're just trying to get our clients to kind of open their minds a little bit to some possibilities rather than just jumping to the first conclusion they reach. Okay, so we'll take like 15 more seconds and see okay, people are writing in some good stuff. Okay. Prize money, raffle, celebrating a charity auction, fundraiser. Okay, there was one that was funny that I wanted to say. You're trying to give her change for a 20, bragging about how much money she won. There was one that I thought was funny. Corey was just presented with her prize money. She's so happy she could cry. Okay, these are great.
Shopped at Goodwill and found a purse. That's very unique.
Yes, that's a good one. Live Monopoly, trying to pay for dinner, and I don't want her to pay. Okay, we do argue about that sometimes. Okay.
Bank, lottery.
Right.
How much to tip? Man, I love these rich people.
Right. Well, that's one that's unrealistic, right? Good. Okay, you guys get the idea. Excellent answers. Thank you. Okay, so, the idea, as I mentioned, is to just sort of think outside the box, teach your clients to think outside the box, and so forth. I'll tell you what this actually was, because it is very bizarre that we would be sitting there with a gigantic pile of money in front of us. And
what's more bizarre is someone took a photo of us.
And then someone took a photo of us doing it, right? Sitting there like that. This is one of those all-time funny photos. And so what we don't want is anyone to jump to the conclusion about what this was, right? So now that we've sort of generated some ideas, I can tell you what this was. It's actually number 4. We're collecting money after a group dinner. And so what this is actually is that we are part of an international CBT for psychosis clinical and researcher group that was started by Aaron Beck, who I think you all have at least heard of or maybe know, to bring researchers and clinicians together for CBT for psychosis to, kind of figure out how to disseminate it and be more on the, be on the cutting edge of what's going on. So every year we have a conference, and a meeting with, all the members of the group, and that alternates between the United States and Europe usually, because it's an international group. And so this particular year, Ocean's 8 personnel, that's a good one. This particular year, it was in Boston, and Corey and I were hosting this meeting. So we did all this planning. It was this whole thing. It's a lot of work. We had like 60 to 80 people, and we would go out for these group dinners. That's sort of part of the conference. And, we organized the dinner, and we figured out what the menu was. There's this nice restaurant in Boston, and everyone's sitting around that you can't see, but there's a big room of people, probably about 80 of our colleagues sitting there. And then at the end, everyone gets tired. We've been working all day, and everyone just decides, it's time to cash it in, so to speak, and everyone just leaves, right? Because it's the end of the conference. And so, Corey and I are just sort of sitting there wrapping everything up, talking to the manager about how to pay, whatever. And so everyone was told to bring cash, but we didn't realize how complicated that would be. So all of a sudden, people are starting to leave for the night to go back to their hotels, and they're just dropping money on the table, right? 20s and 10s and 5s, for the tip and this and the 6 drinks they had and all these things. And so this money is just coming into this pile, and it's sort of flying all over the place. So anyway, we were trying hard to get organized and count it, but it just kind of kept coming in. And we must have looked ridiculous doing it, because we were very confused and trying to do all this math. And someone took this picture of us. So that's what the picture is. And this is when you see kind of a random out of context picture of this, like this, it's just kind of a fun exercise to think about your own cognitive flexibility and what this could possibly be. And oftentimes you're totally wrong. It's something entirely different. Right? So thank you all for engaging in that. It's a fun thing it's a fun party game. If you have some funny pictures of yourselves, it's fun to have your friends and family and colleagues kind of guess what's going on if you feel comfortable with that. Okay, let's see, where are we? Next slide. Okay, we're gonna finish this piece briefly, and then we're gonna take a break, okay? Because I think it's probably time for a break. All of this, what I was just talking about with the cognitive and perceptual underpinnings of how a person with a propensity for paranoia, delusion, schizophrenia sort of has their beliefs develop and get triggered is a really important way to understand how psychosis works. And so this is an example. We're going to take Bryant. So you remember Corey introducing Bryant so well a few moments ago. And we call this evolution of a delusion. So this was adapted by Aaron Beck and Neil Rector, who are colleagues, about how an actual sort of real situation in the person's past evolves into a full-on delusion, right? So there's a lot of nuts and bolts and pieces to this, but this is sort of a summary of how that might look. And there's these different categories. And so we'll just take Bryant as an example so you can kind of get a picture of this. So the first thing is the precipitating event. And the precipitating event is real. It is an actual thing that happened to a person, to a client. Maybe it was 15 years ago, maybe it was 6 months ago, but this is the precipitating event. And in this case, as Corey described, remember they had these neighbors that lived next door that were having parties and so forth. And so the family was bothered by this. This is real, right? Remember? And called the police or made a police report regarding noise at the neighbor's house that happened like the night of a party, or I think it was. So that is the precipitating event. Now, what happened to Bryant was that precipitating event sort of triggered this initial worry or fear. And that worry or fear started to get bigger and bigger. And Brian's initial worry or fear was the neighbors will retaliate. The neighbors are going to be so angry, they're going to do something major to retaliate for what my family has done or what we've done. And then from there, Bryant sort of starts to hone in on all kinds of situations and events that he perceives are related to this. And that's sort of like the selective attention bias that we talked about, right? We call this selective attention to threat. So he starts to monitor the neighbor's house and he pays attention to all the cars that are parked outside on his whole entire street and what's the model and make of them and what do they look like and whose could they be, and just really starts to hone in looking for threat, right? Trying to find it because he believes that the threat is coming and he has to kind of understand what the threat is to sort of maybe start to protect himself or understand it better. So this is selective attention to threat. At the same time, he sort of starts to notice uncomfortable sensations in his head. So like a physiological response, right? And we know that likely that physiological response is stress or maybe medication side effects or the impact of poor sleep, or some kind of, headache or stress or anxiety symptom, right? However, because he has this selective bias or selective attention to threat, he starts to attribute these uncomfortable sensations in his head that are starts to link them up or sort of see them as threatening. Okay, next slide, please. And then from there, we have what we call confirmation bias, right? Which is a term you may have heard of in other areas of life that have nothing to do with this, where the client, in this case, Brian, would sort of take all of everything that he just has been observing for the past week or 3 weeks or 3 months and sort of thinks about it in a way that is very biased, but that confirms his worry or perception of threat. So in this case, he thinks, okay, that car that is parked outside is the car of my former boss who's working with the neighbors, who's trying to ruin my life so that I never get another job again. And it sort of feeds into, this idea that the neighbors are retaliating, right? And then from there, sort of the last piece, which can go on for a while or happen pretty quickly, is this connecting of the dots. And again, thinking about what we saw in the previous slides about that need for closure and that jumping to conclusion and that idea of taking neutral things that people do and kind of turning them into negative things, right? That the research has shown that people with paranoia and delusions exhibit. Connecting the dots, and Brian decides, okay, my neighbor is blackballing me so that I can't get another job. And the sensations I feel in my head are the impact of the wireless technology that the neighbor has sort of put around my house and so forth. And he's doing that to torment me. And there you've got the formation of that delusion, right? And so it's this process, right? It doesn't just happen all at once, although it can sometimes happen pretty quickly, but it is this process. And again, you know, this is the kind of thing that helps you as the clinician really understand how a delusion comes and how it formulates. It does not come from left field. It typically does not come out of thin air. It is connected to an actual event, and there's a series of situations that, or a series of perceptions and cognitions and attentional sorts of processes that contribute to kind of get the delusion into an actual delusion form. So that's an example of how that might look. Of course, it looks different for everybody, but if you use these sort of headings, these categories like confirmation bias and connecting the dots, you can probably create one of these for a client who you work with, just, you know, for your own intellectual exercise of how their delusion evolved from an actual event that happened earlier on. So that's how that looks a little bit. Okay. All right. So we are actually going to take a break right now. You guys have been great kind of hanging in with us for the early part of the day. We'll take about 20 minutes or 15 to 20 minutes. So let's see, it's 10:54 on my time. So like 11:50.
Restart at 11:15. Is that too long, or is that good?
No, I think that's a, yeah. I think,
break. Yeah.
Yeah, I think a break's good. It's hard, you know, for everyone to sort of be here remote online. So let's take about a 15-minute break, but we will start back up because we do have a lot to cover. So please come back. Yeah, let's do that. So what we're going to do is we took a look at some of the great questions that you all typed in, which was really, really glad to hear from you. And, you know, we looked through them, and, you know, what I think we'll do is we'll answer a few of your questions. We've chosen a couple of them, especially ones that were asked a couple different times. And we'll address them right now. And then we also have a pretty significant amount of time at the end scheduled for more Q&A. And so if there are new questions that come up as we present the rest of our material, please do what you did before and put them in the Q&A section, and we'll try to get to at least some of them at the end of the day. Also, if after we address try to answer some of them from this morning, later on, if your question was not answered either by us or throughout the rest of the material, then, and you still would like it answered, we'd ask you to just type it back in again towards the end of our time today, so that we can try to address it at the end of our presentation today during the second Q&A section. Okay. So let's see. So first we'll do the questions, then we'll finish up this section in our slides and move on to another part. So let's see. One of the questions was how to help a client kind of stay engaged when you're trying to introduce CBTP, or when you are you know, working with them throughout the structure of the session, how to keep clients kind of engaged and paying attention if they have struggles with that. Because we did talk about that sometimes can be an issue for people with schizophrenia. And especially if you're working remotely, that has its own sort of set of challenges that we're all navigating these days. But, you know, I think there's a couple of ways to address that. The first is to ask the client directly what's going on if it seems like they're having trouble paying attention. Because I think a lot of times we as clinicians make assumptions about what we think is happening when it really could be something very different. And that's also the case even more so when we're working remotely or doing video or doing teletherapy. So, you know, the first thing I would say is, it seems like you might be having trouble kind of hanging in there with me. Tell me a little bit about, you know, sort of what you're experiencing right now. Because it's a very different kind of way that you would handle it if the client's like, I'm bored, versus I can't understand anything you're talking about, versus the voices are screaming in my head while you're trying to talk to me, right? So you would handle those things differently based on, you know, what the attentional problem was, right? And so the very first thing you want to do is sort of make sure that you understand what the client is experiencing at that moment. It could be negative symptoms too, where the person actually is really paying attention. They're just not facially or affectively showing that to you. And, you know, that's important to know as well. So the first thing is to figure out that you are correct that they're having trouble paying attention, and two, kind of why that is, and sort of address it from there. The other piece is you want to sort of have your meetings be as collaborative as possible, meaning that if you have someone who's struggling with attention and concentration for a variety of reasons, you want to make sure you pause enough and sort of say, hey, just so we're on the same page here as we go forward, tell me what you think I meant when I was just talking to you about what CBT was. What's your understanding of what I just said? And, you know, in a really non-judgmental, collaborative way, checking in with the person to get a sense of that they have some level of understanding and that they are sort of tracking with you a little bit. So that's one thing you want to do. The other thing is, that's why the writing piece helps. That's why I highlighted that in the beginning. And Corey and I do a lot of that with clients. It just sort of serves as like a way to break up a verbal session. And it also serves as sort of a reminder to keep attention going, especially if you write down your agenda. And then sometimes what clinicians like to do is check off as each sort of topic gets accomplished. And so just kind of that little, even though it's sort of like a low level of written interaction, that can kind of help keep someone's attention as well. Similarly, you know, we ascribe to a shaping model with some clients where if they are not used to sitting there for 50 minutes doing psychotherapy, then this is going to be hard, right? So it's okay to start with a 20-minute session as long as you are working actively to increase that over time, even if it's by 2 minutes each session, right? Because, you know, you can't get a ton done in 20 minutes, really, as far as this intervention goes. You really want to have sessions that are a little bit longer, but you might have to shape and get the person used to it. So those are just a couple of different tips as far as that goes for attention and concentration. A second question that I heard that we saw was about homework. And this was in particular to a teen who the person's working with who's struggling or maybe may not be interested or having a hard time getting the client to do homework. And that applies, you know, across the board. Homework is a tough thing. So I'm going to address it a little more generally. And it would be applicable to the teen, to working with teens as well. And we are going to talk more about kind of the nuts and bolts of homework tomorrow. So you can stay tuned for some more detail on that. But again, the response is a little bit similar actually to the response I just gave about attention and concentration. The first thing you want to find out is what the person's attitude about the homework is. What is the concern, right? What is getting in the way? And without understanding that, you can't really figure out how to help them, right? So, and depending on what the client responds, what the client's answer is, that's going to determine really, you know, how you help them with this, right? So if there's a big difference between a client saying, the homework that we set up is not relevant to me, versus I'm nervous that I'm going to do a bad job on the homework and you'll judge me, versus the voices are telling me not to do the homework, versus I didn't really understand what we talked about in session, so I don't know how to do the homework. Those are four incredibly different kinds of responses. And you could not treat all of those the same way, right? So there's a different way to deal with concerns about homework depending on the source of it. So the very first thing you want to understand is what the concerns are or why the person's having trouble doing the homework. And then you want to kind of take it from there. Again, it's kind of like a shaping thing, just like, you know, session time, where at first it might be they do one tiny thing and then text you afterwards and, you know, saying that they did it. And then over time, you know, you're building up towards doing written cognitive restructuring and so forth. But any attempt, the way that we like to conceptualize homework is any attempt at all, really, any attempt at all on the part of the client to attempt to use the skill or anything that was talked about in the session in their own daily life whatsoever, whether it's written down or not, or thought about, that counts, right? And that should be reinforced, because we want to make the client feel good about the idea of doing this, and that you're there to cheerlead them and talk them through it, right? The other piece of this is that you want to make sure that you have provided a very clear and understandable and convincing rationale early on in therapy, and then as much as needed going forward, about why homework's important in the first place, about why you're doing it, and always tie it to the client's goals. So it's not homework for homework's sake. It's not homework because CBT has homework. It's homework because you know that the client has mentioned that they want to be able to be comfortable around people and eventually maybe have a girlfriend. And if that's the case, you know, there's some things that are going to need to be practiced outside of your time with me, your therapist, in order to get you there. And that's why we come up with those tasks together at the end of every session. Does that make sense, right? So it's rationale, shaping, understanding the concerns, and reinforcing any attempt towards skill use whatsoever. So that's, and we'll talk more about homework later on too, but hopefully that addresses a little bit of some of the common obstacles. The third question, and then Corey will answer some other questions, was about the efficacy of doing CBT for psychosis in a group therapy setting versus individual. So what we're talking about in our overview with you is individual CBT for psychosis, obviously. There has been some really, really good adaptations of CBT for psychosis for the group format, and it has been shown to be effective. Now, there are some kind of specifics that are related to having that be effective, and there's two colleagues of ours who have done a lot, and primarily most of their CBT for psychosis work is in a group format. And one of those people is Dr. Tanya Lecomte, who's in Canada, who's done a lot with CBT, group CBT for psychosis. She's done a lot of studies, and she has a great manual kind of outlining that she trains and works with people on. And then the other person is Dr. Eric Granholm, who is at UCSD and was my mentor when I was on an internship many years ago now. And he has a great intervention. It's called CBSST, and it's a combination of cognitive behavioral therapy for psychosis and social skills training for psychosis that has a lot of research done on that as well. So the short answer is yes, it is possible to do group CBT for psychosis. Yes, it has been shown in research to be effective. But also, you know, it's not just sort of willy-nilly group CBT for psychosis. It's typically, you know, a structure and a certain way of doing it. So that addresses a few of the questions. Corey, do you want to jump in and?
Yeah, they're great questions.
The other ones?
Thank you all for being so engaged. And it was really nice to see people's comments in the chat boxes as well as we went on. Thank you for that. So the first question I want to address is, why are some other countries successfully providing treatment without medication, but not in the United States? Okay, so let me tell you what I know about this. I want to start with basically one thing that a colleague pointed out to me one time, which is the myth of the natural history of a disease, okay? And what the myth part is where we sometimes neglect social factors and social determinants of health that have bearing on the outcome of a particular disease course. So for example, if, you know, Jen gets tuberculosis today, she's here in Boston, there are like 18 million hospitals she could go to, she will be fine, okay? If I am in Yemen and I'm living in a refugee tent and I get tuberculosis, I'm likely going to die, okay? So the idea is that the resources that we bring to bear on particular illnesses shape their course. And this is very true for psychiatric illnesses as well. Now, there are some exceptions, I will grant that. There are some diseases that maybe their course isn't modified tremendously by social factors, but I would say that schizophrenia is one that is modified by social factors. So there is a model that was developed in Finland called open dialogue. And in this model, you basically intervene with people very early at a first episode of psychosis, which may or may not turn out to be schizophrenia. So that's kind of an important thing to notice. And in this model,
you have a lot of conversations, you might start medicines that are not antipsychotic medications, and you really try to work with the family system and perhaps even the community that wraps around this person to address their issues and symptoms in a way that doesn't involve antipsychotic medication. These models, this takes a tremendous commitment from the community and from society to do these things. For example, in some countries, you know, the recognition of an early psychosis happens within weeks. In our country, it's still 1 to 2 years before people tend to be identified as having a first episode of psychosis. So there are a lot of factors that play into this that may account for the fact that early research in the United States on this particular method has not looked so promising. That's my take on it. Other people may have other takes on it, but I think that might be at least a piece of why these models are not working here. Okay, another question. So a question about cognitive, is cognitive rigidity generalized in some specific kind of situations or applicable in almost all? That's a great question. And I think it points out an important thing when we're talking about biases. When we're talking about cognitive perceptual biases, they are typically not, in schizophrenia, they're not to everything. They're under situations of stress. So the idea is that under situations where a person has more negative affect or is under more stress, these biases get magnified. And perhaps when the person is really relaxed and in a really comfortable situation, they may be able to actually read a situation very flexibly. So it's not about everything. It's about things that cause the individual stress or about environmental stressors coming to bear. And we all, this is actually pretty normal. We all show more biased thinking when we're under stress and when we are experiencing negative affect than we do when we're, you know, completely relaxed and not under stress. Okay, this is a good question. When thinking about the evolution of a delusion, how do you validate a person's experience without feeding into the delusion? That's a great question. I remember this young man I worked with who had moved from California, or the West somewhere, to Boston. And one of the things that was really hard about working with him was that he told me that his prior therapist believed him, that the mafia and the CIA were out to get him. And the reason he thought they were out to get him was that he had sold a little bit of marijuana. It became very hard to fight against this belief or this experience that he actually had of being validated by his therapist, assuming that was true. And I didn't really have any reason to doubt it. And I can see how it happens that in the effort to establish a relationship with a person who has delusional beliefs, people start to feel like they need to kind of believe them about the experience. The thing is that I think that's the first premise that's really important to challenge. You don't have to believe someone about their delusional beliefs in order to have a therapeutic alliance with them. You have to have a sense of trust. They have to have a sense that you're listening, that you understand where they're coming from, but you can agree to disagree. And the other thing is that you can validate the person's distress without validating the truth of their experience. You weren't there. Sort of like that picture, right, of Jen and me. We were there, so we know what it was. But if we hadn't told you, you still wouldn't know what it is. And you have to kind of like enter in with the person of, I wasn't there, you know, I don't know. As Jen mentioned earlier, it is very rare that people are 100% sure themselves. They often will bring up things that say, you know, yeah, I'm 90% sure. You know, and then maybe there are some things they're not sure about, and you can validate that it's confusing. You can validate that all the pieces don't add up. You can validate how difficult it is for them, but you don't have to validate what their experience is. And I think part of it is in the questioning, because your question is a good one. Sometimes people present it as truth. They don't present it as their interpretation of an experience. They present it as the truth of their experience. So it depends on how you ask the question. Like if I ask Brian, you know, when did you first start to believe that your neighbors were using wireless technology. That's different from saying, when did your neighbors start to use wireless technology? It's a subtle thing, but I am still getting at the idea of a belief. So I hope that we're going to talk more about alliance building, which this actually, I think, talk in the next phase, and some of this dovetails with that. So I think we're going to save other questions for the end, and you can add to them, but for now, those are the ones we're going to introduce. And the next thing we have for you, Jen's going to introduce it, is a bit of a video, actually.
Hannah, could you share the slides? Great. Okay. So this is just a way to kind of wrap up this cognitive and perceptual underpinnings. And so hopefully, you know, you've gleaned a couple sort of interesting tidbits from that, but really the take-home message is that people with schizophrenia and active psychosis, under times of stress in particular, tend to jump to conclusions about things that they are distressed by, and that in jumping to conclusions about those things on a regular basis tend to really impair their functioning in a variety of ways, right? Whether it's in the convenience store or on the job or in relationships, not answering the door, when their family comes over, whatever it is. And so this is sort of one of the things that we're trying to help people learn about, the idea of jumping to conclusions and kind of how to not do it. So this is just a little sort of fun video about jumping to conclusions that we like quite a bit. And we're gonna do our best to have it play for you. It's gonna take a second to set up and get the volume on. Okay, so that's always a good one. There was no speaking in it, so it's okay if you didn't hear, if there was no volume or you didn't hear it. So the poor guy's, you know, trying to make his wife a nice pasta dinner, and, you know, her first conclusion likely that she comes to is that he's trying to murder her cat. And so, you know, these videos, there's a bunch of them, we're going to show another one tomorrow, are great because they're sort of fun and they're non-judgmental and they're non-pathologizing. They sort of show how normal it can be to jump to conclusions, but also why it's bad too. And so these videos you can show to your clients in the context of this kind of discussion when you're sort of teaching them about the thought-feeling model and jumping to conclusions in CBT. So that's a good one. Good. Okay, so we're going to shift gears a little bit. And so I was just sort of broadly talking about cognitive and perceptual underpinnings and how we think about that kind of thing in CBTP. Now we're going to shift, and Corey's going to talk about how we in CBT for psychosis and in the cognitive model understand things like hallucinations. Because understanding them, and again, being able to sort of share that understanding about what we know about them to our clients is really important in helping them to understand their own experience with hallucinations, as well as be open to, you know, working on some strategies to help them cope better. So Corey, you want to take it over?
Thanks, Jen. So, you know, a lot of this is people come in with some idea of where the hallucinations are coming from, right? And you're trying to help them reattribute the hallucinations to something else, to a different understanding that's going to make sense to them and perhaps be less threatening and more benign. So how do we think about hallucinations? Well, I mean, I think one of the most interesting parts about hallucinations, and something that we probably never think about, is that when we're dreaming, we are actually conjuring the voices of people we have not seen in perhaps a very long time. Right? So how is it that I can hear the voice of my fourth grade friends in a dream while I'm sleeping? It's in there somewhere, right? So, I mean, that helps us with maybe voices that are remembered, which is often the case with voices, not always, but often the voices that a person is hearing are actually the voice of an actual person that they know that is reintruding into their consciousness. So it's kind of like they're dreaming while they're awake. They're having that that switch, whatever that switch is that's supposed to turn off, is not turning off, and they're hearing these voices. The other idea is that they're a form of automatic thoughts, perhaps negative automatic thoughts, that are experienced as coming from, an external source, or, an external source, but still inside the head. What's really interesting about that, and, something that we don't understand really, is that when I'm thinking an internal thought, I probably am thinking in the I version, right? I'm probably thinking I'm screwing up, like that might be my thought. But when I'm hearing a voice, if I'm a voice hearer, I'm probably hearing it in the third person. I'm probably hearing you are screwing up. So it's not exactly my own thought, but it's related to my own thought in some way. But the form it takes is a little bit different. And the form it somehow takes is the form of being observed by something outside of me. But, there's also the idea that hallucinations are kind of a form of mental garbage, right? We have all kinds of thoughts during the day. Sometimes I talk to clients about these as like infomercials. If you're listening to an infomercial for something that you don't care about, you probably can kind of block that out and not tune into it. But for people who are hearing hallucinatory experiences that are distressing, it's usually a mental kind of garbage that they can't not tune into. They have to tune into it, so it feels relevant to them personally. As we mentioned earlier with Charlotte, they can serve the purpose of creating a social world. If that's your hypothesis, that that's what's going on, what should happen when the person gets more connected, in the real world, is that the need for the voices should sort of fall away, and they shouldn't have to have that as much as their social world. But, when you think about what's maintaining the distress associated with hallucinatory experiences, and these are some of the points of intervention, there's sort of how are people attending to the voices? So that attentional part that we talked about before, how much are they honing in on it? I like to think about this almost like if anyone treats chronic pain, one of the things that you do in a CBT approach to chronic pain is you change the idea of focusing in on the pain or scanning for the pain. So if you're scanning for voices, which many people will tell you once you start talking to them about that they do it, that they anticipate the voices and they look for the voices. Not that they want to hear them necessarily, but it's sort of like having a toothache, and like you just kind of have to like touch it with your tongue. They do that with voices. Certainly the meaning that's attributed to the voices can really change a person's distress, and we'll talk more about that specifically. And how people think about the voices. I've always thought it's really pretty interesting that people don't tend to hear the voices of benign others, right? People don't hear the voices of some cute little 4-year-old talking to them most of the time. They hear voices that scare them, of people who are powerful, mean, and who know a lot and who have a lot of power and control over them. And so the other question, always with the way people, when you're thinking about attributions and the way people make sense out of things, there's how do you make sense out of the threat? And then how do you make sense out of your own capacity to cope with a threat? So the worst possible recipe is when a person perceives themselves as pretty incapable of dealing with a threat, so that I have low power and control, and they perceive the threat as very, very powerful and as having very dire potential consequences for them. So these are all cognitive aspects that you can work on with hallucinatory experiences, but before you work on them, you have to understand the framework and why we're thinking about these as places to work. Okay, next slide, please. So here's like an example of, maybe sort of a diagram you would draw with a client, or even, a thought record. So the person hears a voice, right? So there's these are idea that voices trigger all kinds of appraisals in response to the voices. And that's a whole domain to work on. So I hear a voice. I think to myself, if I'm Charlotte, for example, the voices are powerful. I shouldn't go out because they say not to. I'm distressed. I avoid. The avoidance kind of, builds on itself, like we know avoidance does, and magnifies the distress over time. but it works to short circuit this distress in the short term. So in the short term, it kind of works, right? It's like, okay, now I feel better. I did what I did what the voices said. But in the long term, I've decreased my own sense of my power and control responding to the voices. I've increased the power of the voices. Perhaps that distress actually folds back on itself and eventually increases the hallucinatory experiences themselves. So that's like an example of how, you know, I think what's so interesting about working with psychotic symptoms is to get to thinking about the thinking, not just the symptom. Don't look at the symptom itself, look at the thinking about the symptom. Okay, next slide. So other things that maintain hallucinatory experiences. So we talked about avoidance or compliance. You know, a delusional explanation for the hallucinatory experience can often maintain it. You know, the more need for closure that the person has, the more crystallized that delusional explanation is going to get, and perhaps the more conviction the person is going to have in that delusional explanation. So, you know, there is a point with someone like Brian where he believes that maybe it's nanotechnology or whatever he's calling it here. He doesn't go necessarily from, I'm sure that it's nanotechnology overnight. But over time, if that delusional explanation is kind of reinforced or he becomes more invested in it, it becomes harder to work on the hallucinatory experience. We talked about how potentially negative core beliefs might give rise to, you know, a lot of negative automatic thoughts. And if this person has this vulnerability to have their internal thoughts experienced externally or experienced as voices, they may just, you know, have more voices or more distressing voices. So the degree to which a person thinks I'm a loser, that's going to make a difference. If they're a voice here, they're probably going to hear more derogatory negative voices when that belief is activated. The more they believe that they're a good person, that they had value to the world, that they're loved, probably the less likely they're going to hear those derogatory voices. You know, I mentioned before about Charlotte, and this is something we see a lot, that voices tend to be worse for people in the afternoons. It's a little bit like, you know, what you see sometimes, I think, with memory problems, with dementia, that people seem to do better in the early part of the day, and they get, as they are tired, you know, they call it sundowning, I guess, in dementia, people start to get kind of tired and they don't have as much to do, and they're sort of sitting alone with their thoughts, and they don't do as well. And it happens an awful lot with voices. We often do, you know, one of the most common things, and anyone who's worked with people with voices will know this, is that people talk about work as a time when they're not hearing as many voices. Very commonly, that's the time when the voices are not as active. And we'll talk more about why that's the case and how we can use that actually in a coping strategy enhancement way later on. Ruminatory activity sort of maintains voices. You know, voices are very ruminative, right? When you start actually recording with people what their voices say, what you see is very commonly the same exact phrase again and again. I'll never forget a young woman I worked with who was always hearing, "You're a waste of space. You're a waste of space." And she probably heard that 300 times a week when she was really hearing a lot of voices. So it's almost, you know, they have a ruminative, perseverative quality. And social isolation often is a factor that would maintain the hallucinatory experience and make them worse. Okay. Next slide, please. So now we're going to talk a little bit about different phases of therapy. And kind of as we mentioned at the outset, we're going to focus really mostly on the first three phases, which is, you know, engagement, phase 1, assessment and goal setting, phase 2, and then really interventions, phase 3. There are other phases, but they kind of come later, and there's only so much you can do in 2 days. So let's go into a little bit talking about engagement strategies, particularly thinking about paranoia, because I think paranoia is perhaps one of the hardest places to think about engagement. So we can go to the next slide because I just mentioned these phases. Okay, great. So what are you trying to do in introducing CBT, which we demonstrated before? You know, I think a common misconception of CBT is that the alliance isn't important. The alliance is important in every type of therapy, probably every type of prescribing of medicine, every interaction you have with people who are having mental health challenges. So it's critical that you establish an alliance with the person. You want to also teach the cognitive model. And you saw from Jen's example, when she was the therapist introducing CBTP, she's starting to talk about the cognitive model. She's starting to talk about, like, what kinds of things do people think when, you know, they're feeling depressed and they hear a knock at the door? What kinds of things did they do? That is the cognitive model, essentially. How do you behave? How do you think? And how does it affect your emotional state and your physical state? And then there's a fair amount of normalization in psychoeducation, which we'll describe some elements of. Next slide, please. Okay, so, and you saw Jen do this too. Hopefully this kind of stood out, was you want to convey specific expertise to people. When someone comes to me and they, you know, think that they're Satan, or they are hearing a lot of voices, they want to know that I've seen this before. They don't want to think that this is my first time ever working with someone with these experiences, because how can they have any faith in me or belief that I can actually help them? So it's really important to think of ways, you know, to both, you know, you don't want to make them seem like they're a dime a dozen, or that their experiences are, or minimize their experiences or anything like that. But you do want to make it clear that you've worked with this before, that you've worked with people with similar challenges. Of course, their challenges are unique. And that you've seen people do really well. You want to convey hope. It's really important to empathize with their distress and, you know, not collude with their delusional beliefs, which means in the beginning, you can actually say, I'm in an information gathering phase. I mean, you just came to me today and, you know, I don't know, you're asking me, why do you believe you're Satan? I don't know the answer to that. I need to hear from you a lot more about this experience, how these beliefs developed. We need to work together and get to know you as a person. And then together we'll put our heads together and try to figure out, you know, where this idea came from, where some of these experiences that made you believe you were Satan came from. Something also that's a little different maybe about CBT is the first thing when someone tells you that they're paranoid about you, the first thing that you say is, I'm so glad you shared that. Thank you for sharing that. And in fact, you try to set the stage when you're even forming the therapeutic alliance to say, this might be different from some other things that you've been involved with. If you get worried about anything, I'd like you to let me know at the moment, if you get worried about me. Now, it's really common that people say, people who are paranoid about everyone, somehow they come into treatment with you and they say, oh, you seem nice. I don't think I'm going to get paranoid about you. But of course they will. And, you know, someone had a question about writing notes. You know, what you want is, if someone is nervous that you're writing things down, you want them to say, why are you writing things down? Where is that going to go? You want them to have control over that piece of paper. Are you comfortable with me writing things down today? This is the reason we do it. We can talk about what you want to do with the piece of paper afterwards. You know, usually I give a copy of what we write down in session to you, and I keep a copy. I'm okay with giving you the original if that's something that you'd feel more comfortable with. You can certainly let me know if you don't want me to write down certain things down. You can let me know and I won't write them down. You know, or, you know, maybe it's not comfortable yet to write things down. Maybe we can write down, just at the end of the session, we can agree to write down the most important thing that stood out from today. Because part of the reason you're writing things down is to have some retention of what's happening in your work together for the client, not so much for you. You have your notes, right? But what does the client have if you're not creating something out of the session? So also really fine, and in fact good, to genuinely care about your clients and to communicate that care. I care about you. I'm concerned about you. I want things to go well for you. That is actually, sometimes when people are very suspicious of me and I say that, it actually calms them down right away and gives them some reassurance, which, you know, reassurance isn't always the kind of thing you want to supply in all therapy with all people, but for some people that actually works quite well. You want to be flexible too. You know, you don't want people to feel like you the more of a power differential, and there's a lot of work coming out about this that's really interesting, about how people with schizophrenia can look a lot more symptomatic under therapeutic conditions, putatively therapeutic conditions that induce stress. So if people feel interrogated, if they feel a huge power differential between the therapist and the client, they're likely to actually be more stressed out and more symptomatic. That's not so difficult to imagine. You know, I probably would feel the same way. So I think that thinking about ways that equalize, you know, power, collaboration, that make you, you know, you're human, you're flexible, you're fallible, all those things need to be communicated. Okay, next slide, please. I mentioned before the idea of agree to disagree. You know, at some point when you have gathered enough information and the person is saying, you have to believe me, you have to believe me that this is happening, you can say, you know, I care a lot about you. I hear how difficult these experiences are. I do not want to invalidate your experience of distress, and I understand that part, but we're going to have to, you know, come to the point where we still can work together, but agree to disagree about the cause. You know, it's a very, unless you do that, right, how could you even explain that you're supporting that this person takes antipsychotic medication, right? It's sort of, it would be very disingenuous to say, I agree with you, but I also think you need, you know, this medication. Fading empathy is something that I think is important to remember because, you know, many of us who've worked with people with longer histories of illness, you could work with someone for, you know, a year, 2 years, whatever, and the story that they're telling you about what happened to them and the traumatic experiences that they had that may involve some delusional content might sound exactly the same on day 1 as they sound on day 365. And the first time you hear it, you're very empathic with this person and you really are with them and you're, you know, doing all the right things. But are you still doing those things when you heard it the 365th time? And you probably aren't, and it may be a very hard thing, and it might be something you have to work on in your own supervision about how to still remain empathic. Because for that person, it hasn't changed. So it doesn't make sense that your response would change to them. And then we're going to talk more about normalizing and destigmatizing psychosis, I think. So we'll do some specifics on that. Next slide, please. So yeah, so Jen mentioned this, that the psychosis is on a continuum with normal experience. And this is, I think, where CBT had such a late entry to working with people with psychotic disorders, is there was this idea that like psychosis was over here and like anxiety and depression were over here, and they were not part of the same thing or the same spectrum. But actually, you know, there are ways of thinking about, first of all, lack of insight is something that also exists in many disorders. You know, people think about it as, and I often will get referrals, people will say, well, isn't it strange that this person could have schizophrenia and still has some insight? Like he comes in and he says, I know this is crazy, but that's actually very common in schizophrenia. People believe it and they don't believe it. But, you know, does the person who thinks that they're a loser and that they should kill themselves, does that person have insight? No, right? So does the person who thinks that their plane's going to crash, do they have good insight? I mean, in a way they don't, right? So I think that that was artificial, and actually that we can relate to these experiences, and we all make mistakes in thinking. All those biases that Jen talked about, some of them are actually oddly normative biases. So, you know, for example, when something good happens, the normative bias is for me to attribute it to internal causes, for me to say, oh, good things are because of my own efforts. Bad things are because of external efforts. And sometimes people with paranoia actually show both a personalization bias for bad things, but they also can show an externalizing bias for bad things. I also, whenever I'm doing like a workshop or a family session and I'm teaching about psychosis, I'll sort of say something like, you know, okay, so who in here has a brain that's capable of experiencing psychosis? And usually the parents don't raise their hands, and the kid does raise his hand, and then I raise my hand, because all of our brains are capable of having a psychosis. We don't know what our biological vulnerability to psychosis is, And so we don't know what stress it would take to tip the scales, but after enough lack of sleep, after enough, trauma, after enough sensory deprivation, we would experience psychotic experiences. Certainly with, drugs, hallucinogens, or whatever, we would all experience psychosis most likely. But basically anyone could have evoked psychosis. We all have fallible senses. We all make mistakes and errors of judgment and perception. In fact, when, Van Oss and others have done work looking at huge samples, mostly in Europe, of who reports hallucinatory experience, who reports something that could be considered a delusion, you see up to almost 10% of the population reporting something that could be sort of delusional. And 5% of the population reporting hallucinatory experiences. So the experiences themselves are not necessarily the problem. The problem is when the experiences are impacting functioning and distress in a way that's making the person unable to sort of, live a good life. There's a lot of myths out there about psychosis and schizophrenia, and people don't have a good basic understanding of what the diagnoses mean. They don't understand that psychosis is a non-specific symptom, right? Psychosis could be because of trauma. It could be because of substance use. It could be because of schizophrenia. It doesn't tell you that the person has schizophrenia just because they have psychosis. And schizophrenia doesn't mean, one of my clients, she said, I went to my PCP and I told her that I thought I might have schizophrenia because I was doing some work on the internet. And my PCP said, "Oh, stop, you're just worrying. People with schizophrenia are homeless and live like under bridges. You don't have schizophrenia." I love to show this little, if there's any Harry Potter fans out there, or people who have kids who are Harry Potter fans, there's a clip actually in one of the Harry Potter movies where Harry Potter is hearing voices. He's hearing voices of the snake. And Hermione says to him, "Harry, even in the wizard world, it's not a good idea to tell people you're hearing voices." So these messages are very reinforced, and we have not made the shift as a culture to teaching kids or adults, certainly, that these things are not, they're not so weird or taboo or terrible that you shouldn't talk about them. And, when we think about things like obsessions, right, we know that when people keep obsessions and compulsions secret, those things get worse. That's actually one of the things you work on in OCD. It's the same thing with this. It's emotional suppression and experiential suppression. And that is going to lead to more distress and more problems. Because our society does stigmatize mental illness, and particularly schizophrenia, people start to develop ideas about themselves because they have schizophrenia. Many people you will work with, when you look at their voice logs, part of what they're hearing, and in fact, Charlotte is a good example of this. She hears voices saying, "She's a paranoid schizophrenic," and she'll say it in that voice. "She's a paranoid schizophrenic." Why is that something that she hears? She hears that because she believes that this is bad and that she's a threat to society because of her illness. So these are the kinds of things that you want to work with. Okay. Next slide, please. Okay, so now we have a little video, and this is, these are actors. These are colleagues who work with CBT for psychosis. They are British, so you have to pay a little attention to the accents. Let's hope that the audio is working, because you really need the audio for this one. And what you're going to see in this video is you're going to see an engagement process with someone who's reporting hearing voices. And this involves, some psychoeducation sprinkled in, some normalization, some helping the person, some empathy, certainly. And I think this is Doug Turkington playing the therapist here. He's an author of many good books on CBT for schizophrenia. So hopefully you'll enjoy it.
And Hannah's working on the volume to get
Tony,
that.
you've been given the...
Works great. Okay. Thanks, Hannah.
Diagnosis of schizophrenia by one of your doctors. I just wondered what it's like for you and what the main problems are.
The main problem is these, well, they tell me that it's a problem to do with my schizophrenia, is these voices. They come and I hear these people talking about me and talking about how rubbish I am and what a failure I am, and I really just wish they'd leave me alone.
Yes, it's extremely negative content to what's being said. So it's a clear voice outside of your head, is it?
Yeah. It's two voices, and they sometimes they talking to me, and sometimes they're talking about me, but it's always really negative. There's no helpful things there at all.
It sounds like these voices are associated with a feeling of sadness. Am I getting that right, or is it another feeling?
When I let them, they get me really down. They get me really, really down. But I'm fighting them still.
What are you doing to fight?
Well, there's where I get into a real problem, because I shout back at them, and my neighbours they don't understand, and they say they don't hear these voices. And sometimes I wonder if my neighbours are in on it as well, but they say that that they can't hear them, but I don't understand how they can't hear them, because they're so loud.
So loud?
Yeah.
What do you make of these voices then? Do you think it's part of an illness, or do you think the neighbours are doing it, or what do you think?
Well, I think there was somebody once that I really didn't get on with at school, and I think it's him, and I think he's kind of got these people to be kind of harassing me. I think they're trying to drive me mad. I think is what they're trying to do.
It's a very distressing experience. I can understand that. So, do you think other people can hear them if they're very loud?
Well, you know what, they say they can't, but that makes me wonder if they know what they're, if maybe they're on it, in on it. But everybody says that they can't, and I don't know. I've tried. My CPN said, why don't I put a recorder on, when the voices are there, and it didn't pick them up. But I don't know, maybe it was faulty or something. It just nobody else can hear them, I guess, is the answer to your question, or everybody says they can't.
Even with the tape recorder, you still don't think that, well, you think other people maybe can hear them?
Well, sometimes I think people can hear them, and sometimes I think, well, maybe my CPN's right. Maybe it's my imagination.
So is it just you that hears voices, or do other people in society hear voices, Tony?
Well, there's somebody else at the day centre, and he hears voices that other people can't hear, and we've talked together, and I can't hear the voices that he's hearing.
That's interesting, isn't it?
Yeah.
And I wonder if there's certain types of stress which can make anybody hear a voice. Have you ever heard of that kind of a thing?
No.
Because quite often soldiers coming back from the war will be hearing the sounds of battle, gunfire and helicopters, etc. So they're not actually there, but they hear them as if they're real.
Right.
And it's linked to the stress of being in a war.
Okay.
Do you ever find that your own voices are worse if you're not getting a sleep, if you're sleeping really badly?
Definitely. What I find is that sometimes I when I get really worried about what they're doing to me, and I think, well, maybe I'll stay up, and just in case they're gonna kind of pull some tricks or something in the night, and times when I do that, actually I do hear them more, the next day.
So maybe lack of sleep has something to do with voice hearing. And this is very commonly seen in society, that the longer that people stay awake, the more liable they are to hallucinate. What about drugs? Are there certain drugs that cause voices? What do you think?
I don't know. I guess I've heard people talking about being a bit paranoid when they take cannabis. But
Yeah.
I don't know whether that would be.
I mean, there's other types of drugs that make you see things, like, well, you know, anyone that's taking LSD or anything really nasty like that.
Yeah, I've heard that.
Can really make you hallucinate things that aren't actually there.
Yeah.
So there's lots of possible causes. It seems like the human brain can very easily hallucinate under certain conditions.
Right.
And there are certain things that can keep that hallucination going. So it seems like about 8% of society will have a period in their life of hearing the kind of voices that you're hearing, Tony. But the vast majority of them will get better again.
Right.
So
8%.
8%. So it's a very common human experience. But at the far end of that 8%, there's a group of people with a diagnosis of schizophrenia, because their voices are so distressing. They're hearing them day in, day out, and they're really affecting their life. So that is where that kind of label comes from.
Yeah.
Basically, everybody at some point has had some kind of hallucination, whether it be hearing things, seeing things, feeling a touch.
How do you know that?
Okay, great. So hope you enjoyed that video. It kind of just brings to life how you would have a conversation with someone about their experience with voices. And I think there's some really important things that are contained in this video that Doug does to engage the client, validate, normalize, etc., without colluding, right, which is something we had talked about earlier. What we thought might be helpful is if you all are willing to just type a little bit into chat, some of the things that you observed that stood out to you about the way Doug, the therapist, was interacting with the client, some of the things he was saying or doing, things that really stood out to you from, you know, kind of maybe a CBT perspective or some of the stuff that we've talked about so far. So, you know, kind of like we did with that other exercise with the photo of Corey and I, we'd like to hear, you know, just some of your impressions about that.
Yeah, and while you're typing, I mean, one of the things that I think is so artful about this is the idea that you're both assessing some stuff in the person and providing information. It's not like you pull out a worksheet. Not that you can't do this, but you're not necessarily pulling out a worksheet and saying, and let me tell you everything I know about voices, right? It's this conversation which then feels very relevant to the individual and gives you a chance to empathize with what they're going through.
Absolutely. And there's some great things coming in, some really excellent observations. And some of the highlights that I'm seeing here are curious and non-judgmental stance, right? Calm and professional. And all of that together is sort of the spirit and the attitude of what you want to be as a therapist. And Doug obviously does a great job with that. One thing that stuck out for me that someone chatted in about was this idea that rather than just sort of telling the client, first asking the client what his experience is using a sort of Socratic style. And we're going to talk about this, like, I wonder about the voices versus here's what's happening with your voices. It's a very different stance, and one that, you know, we want people to understand that's so important to adopt in CBTP. So the hearing the client's experience before offering up what you have to say as a therapist. Figuring it out for himself, right? That's the Socratic collaborative style. And checking in with the client a lot. Yep, those are all things that I'm seeing coming in the chat, which are just the right things to highlight. So I'm glad you all are picking up on that. And that normalization piece, that cannot be overemphasized, right? You know, that is something that is the key to helping a client feel safe, helping a client be willing to open up, reducing a little bit of that hopelessness, all that kind of stuff. You know, I like to think about normalization as, you know, you're trying to help the client feel like he's not crazy, you know, and that is such an important thing for a client to be able to experience in order to get unstuck and be willing to move forward with you.
Excellent. Great. Thank you so much for those reactions. And yeah, we like sharing some of these videos because sometimes it's, you know, and it's interesting to think about how different this might be from, you know, ways you've spoken with clients before about voices or ways they've been spoken to about voices. Okay, so I think we're going to switch back to the slides, and now we're going to talk about phase 2. So now you're, you know, I mean, it's artificial, right, to say that these are phases that like happen in time and like you're going to establish your alliance and then you're going to start doing assessment. You are always doing everything. So once you're always trying to establish an alliance, you're always doing assessment. But we're doing this for teaching purposes to sort of talk about the meat of a particular time and the task of a particular time. So now when we talk about assessment, what we're going to be thinking about is actually using like measurement-based care, right? So when we talk about using like self-report surveys or mostly interview-based, clinical interview-based surveys or assessments, we're trying to do a few things. We're trying to get a baseline. We also want to track progress. And I would say that in supervising people, like students who are doing CBT for all kinds of things, I think this is commonly one of the things that gets missed, is choosing an assessment that is going to be actually tracked throughout the time in your work with the person, and it's critically important. We're going to also talk a little bit about a broader case formulation. So you'll remember at the beginning we did those sort of nugget case formulations that were very kind of quick and dirty. We're going to talk about how to do a broader, more kind of extensive case formulation that involves a conversation with the client about their history, and then how do you actually develop a problem and goal list. Next slide, please. So why is assessment important? You know, when you ask about things in an assessment that the person has experienced, you are implicitly conveying a certain expertise. And you're also normalizing this to some extent. You're letting the person know other people have experienced this. There's a measure created to assess this, so other people have clearly endorsed it. So it also provides distance from the experiences. The minute people start kind of studying their experiences, their psychotic experiences, and I think it's particularly interesting in psychosis, because think about it, in psychosis, people are often feeling studied themselves. They feel like they're being judged, evaluated by the voices, they're being tracked, monitored by the persecutors, etc. So instead, it's this different thing where they are starting to get some distance from their symptoms and start to study their symptoms. It helps people make sense out of what's happening. It also, you know, gives a sense of like a finite issue when people are kind of looking at assessment. You know, it's not that everything is wrong, it's that there are a few things that are not going so well. It's really important for guiding the case formulation, and it can help you, you know, tailor the treatment to that individual, because, you know, one person's treatment isn't going to look exactly like another person's treatment. As we mentioned, it's going to give you objective feedback on what's happening in the therapy, and it also, you know, it's not just about what's wrong; it's also about what's right. You know, that you can celebrate progress. And it can give people a sense of better control over their life and over their symptoms. Next slide, please. So some tips on how to do this. I mean, like Jen was saying before, rationale is everything. You know, you don't want to just spring things on people without any idea of why is this important. So they should understand why you're doing measurement-based care. And you really want to make sure that you have consistency. We typically recommend like every 3-month assessment, and we recommend being focused and clear in your assessment so that you're not doing like a burdensome, you know, 2-hour assessment. Rather, something that's kind of quick, that can take maybe less than 10 minutes, 5 minutes,
from beginning to end. And we're going to be demonstrating actually how you might do some assessment. One of the really common things that Jen and I hear on tapes, well, there's two things. We hear people apologizing for homework, sort of like, they say, I need to do this. I'm so sorry that you have to do this assignment. I know it's hard. You're probably not going to get to it. The same thing with assessments. People apologize. The clinicians apologize for the assessment. It's not something to apologize for because it's for the individual. So the minute you start apologizing for it, it's like it's clearly for me, it's not for you. So it's really important not to rush it, not to apologize, to give it the attention it deserves. And part of it is also that this is collaborative and shared. You're not doing an assessment so you hold some private information about this person that they're never going to see. You are sharing the results of the assessment and how you're using it. And also, does it match the person's subjective sense? You know, it's always really interesting. Part of this, of the CBT session structure, is to check in. You know, so how are the voices this week? Better, worse, or the same? And if the person says, oh, they were much worse, but the assessment says they were better, that's kind of interesting. And you have to kind of, you know, reconcile those two things. However, if they're both the same and pointing the same direction, you've got kind of more to work with, and you know that, you know, you're actually kind of measuring the same thing, speaking the same language. Okay, so let's talk about some specific measures on the next slide, which you don't have to remember all these or know all these. I think these are actually some of your handouts. Let me make sure that that's true. Yes, so the P scale is one of the handouts that you have. That is a measure to assess paranoid beliefs. It's a super simple measure. It probably takes 4 minutes. We're going to demonstrate a little bit how it would be to do that. Another measure is called the PSI-RATS, which actually measures delusions and hallucinations. Then there's a really interesting measure that we'll talk about later called the BAVQ, the Beliefs About Voices Questionnaire Revised. And that is assessing a lot about the person's beliefs about the voices, which is extremely handy when you're trying to do cognitive behavioral therapy, because you need to know those beliefs in order to intervene with them. You know, you could use the PHQ-9 for depression, whatever your agency uses. There's also certainly the BDI-2, which is interesting. It's a great measure, the Beck Depression Inventory, because it gets at those cognitions again. You know, Beck was the father of cognitive therapy, so not surprisingly, there are items in there about how a person is thinking about themselves that can kind of give you a little shortcut to working on your belief work. And then the Calgary Depression, so that's a suicide, that's a schizophrenia specific measure for depression. So it tries to take out the contribution of negative symptoms and instead just measure depression, which, by the way, is a core feature of schizophrenia. So we typically see depression in schizophrenia. So it is worthwhile to measure. Overall psychopathology, the brief psychotic rating scale, the positive and negative syndrome scale, the PANS, as it's referred to. It's a fairly long measure. It's kind of a gold standard pharma measure. Like a lot of times if you're doing a psychopharm trial, that would be the measure that people would use. The scale for the assessment of negative symptoms is one of the measures for negative symptoms. These are hard to measure. These are, if you don't know these scales, they're kind of difficult. There are more modern scales that are a little easier for negative symptoms. Trauma, OCD, anxiety, etc. So you should, pick what are you going to make inroads in. That's what is your treatment going to make inroads in, and you should work on measuring that. So maybe you want to make inroads on paranoia and depression. So you would pick maybe the P scale and maybe the BDI-2. And that would be the measure that you consistently do throughout treatment. Okay, I hope that makes sense to people. We are next going to do a demonstration about how to talk about assessment, because it's not enough to just like pick your assessment and then hand it to the person. That's not going to go very well. That's not woven into the fabric of your treatment. And that's what you want. You want assessment to be woven into your fabric. So Jen and I are going to spend about 10 minutes on this. And we're getting close to the end of the day. So if people want to have questions and start generating questions in the chat box, that would be welcome. For this assessment, one second, I just have to get my notes together. I'm going to be the therapist, and Jen is going to be the client, and the client's going to be Brian. 1 second. Okay. And for this, Jen is Bryant, and we're going to be talking, let's say this is about session 3 or something like that. So typically we want to introduce an assessment fairly early in the course of the CBTP, but you may not want to do it on the very first session because you're working on the alliance, right? So this is somewhere between sessions 3 and 6, I would say. And what I'm going to do is I'm going to talk about the rationale for a measure. I'm going to introduce the actual measure. We're going to start using the measure. If you guys want to look at, if you happen to have the P scale, that's the measure that we're going to do. So you can kind of follow along because we're going to talk about specific items, and we're going to role play taking that measure a little bit together.
The P scale is one that got sent in your packet. So that's one of the ones that we shared with you if you have the ability to take a look at it while we're doing this.
Excellent. Okay. So let's roll our role play. Okay, Brian, so one of the main principles of CBT is that it's really important to evaluate whether the therapy is working by using measures that would be tailored to our goals of what we're actually trying to do together in therapy. So what we'll do is we'll complete these measures together at least a few times during our work together, and then we'll look at how the scores are actually changing over time depending on what we're doing in CBT. Does that make sense?
So like a test kind of thing?
Well, I mean, some people might think of it as kind of a test, like a self-assessment maybe of like how things are going.
Like how I'm doing.
Yeah, like how you're doing. And
Okay.
so, you know, since one of the things that we're working on is like you want to feel kind of safer in your house and in your neighborhood, right? Do I have that right?
Yeah, I don't know if I can though. I mean, it feels really awful there. I don't see how it's possible to be safe under the circumstances. I just don't really see that.
Yeah, I know that at this point we're just starting out, and part of why you came to work with me is that you are feeling so unsafe and it's been so difficult.
Yeah.
Yeah, I get that. But by the same token, some of the things that we're going to do together have a really good chance of making a difference in helping you. And
Okay.
you know, even you just being here today, I know it's not easy for you to leave the house, and the fact that you came today is really great that you're kind of fighting.
Yeah, I'm trying. I don't know, but I'm trying.
It shows that you're trying. So let me hand you this measure because I want you to look at it while I'm looking at it too. And this is a measure that we call the P scale. And what we're going to do is take this together. You know, you're going to respond. I'm going to walk you through it. And what we'll do is we'll look at your score. And this is a measure where a higher score means you're feeling less comfortable in public, and a lower score means you're feeling more comfortable in public. So we're going to work on trying to get that score down.
Okay.
Okay, but I want you to answer really honestly. And if there's ever a question you don't want to answer, you want to skip, that's completely up to you. You don't have to answer every question. Okay. So I thought maybe we could get started and do it today.
I think I get it, but like based on what I write down here, like, is there a score that's like bad, like a bad score? Like I don't want to get a bad score.
Yeah, well, that's a great question. So like for some measures, you know, there's sort of like a score, like if we were measuring depression, for example, there might be a score that we would call like a cutoff score. And anything higher than that might mean that the person looks like they have like significant depression or something like that. This is a little bit different because this isn't a measure where we sort of know what the average score is. We just compare everyone to themselves. So we're not really concerned, you know, we're concerned with where you start in the sense that that means, you know, the higher you are, the more distressing you're feeling. And we don't, you know, we want you to not feel so distressed, but it's not like there's a bad score. We're just interested in how the score changes over time.
Okay.
Okay, so why don't we get started? I'm going to say like a statement and you tell me the response that best fits how you feel about that statement, okay?
One of the statements on this paper.
Exactly. So we're gonna start with the first one. So
Okay.
this is the first one. You probably see it there. So someone has it in for me. And here are the choices. So you see the different possibilities. Do not agree at all, unsure, agree a little, agree a lot, agree completely. So what would you say is the way you feel about that statement? Someone has it in for me.
Yes.
Okay. So the task is to actually pick one from the choices there. So these are the choices. Do not agree at all,
No.
unsure, agree a little, agree a lot, or agree completely.
Well, that's absolutely happening. So I guess I should put agree completely.
Okay. Now, how about this next one? I sometimes feel as if I'm being followed.
Agree. A lot.
Okay. Okay, so fast forward. We're at the end of it. Okay. So now what I'm going to do is I'm going to show you, I just scored this, and basically the way I score it is I just add up the points for each one of these items. And the total I get for your starting score here is a 53.
Is that bad?
Well, like I said before, so that's just where you're starting.
Okay.
So this measure, you know, you could have a higher score and you could have a lower score. So because we want to help you with this feeling of feeling uncomfortable in public, we're hoping that our work together means that this score is going to go down.
Okay. Yeah.
So if we looked at some of the ones together that you agree the most strongly with, right? So which ones kind of pop out there?
Well, I said it was true for feeling followed and that someone's been trying to influence my mind. That's that wireless technology that the neighbor's doing.
Yeah. Yeah. And this one here, that the sense that people will use unfair means to gain a profit or an advantage.
Yes.
Right.
Yes.
That was my one.
That's why I can't get a job or anything.
Mm-hmm. Okay. And were there some others that were also, that you scored at the highest level there?
Well, this one here, I'm sure I have been talked about behind my back. People have said unkind or insulting things about me. I know that's, you know, that's what's that's the whole thing that's happening with the neighbor and my old boss and stuff.
Okay, so primarily the neighbors and your old boss you feel are doing these things. Okay.
Yeah.
Okay. All right. Well, so this is our starting point. And as I said, we're going to do it again in a few months, and we're going to see what impact we're having on this. Do you feel like it gave you a good picture of some of the difficulties you're dealing with currently?
Yeah. I mean, like I knew already because that I'm like, no, that I like know these things are happening, but like it's like this was like really spot on. Like, how did it know? You know, maybe other people, this happens to other people, like they're in the same situations. I don't know. It's kind of weird.
Yeah. Maybe I've heard other people say that before, that they don't feel like they're so alone because there's been an assessment written about this. So obviously this is a problem that other people have dealt with as well.
Yeah. Huh.
Well, the reason it's spot on is because you've done such a good job explaining what you've been going through. So that made us able to really pick a measure that, hopefully would have the biggest impact. So this is what we're going to be looking at over time and helping me understand too. I'm going to make sure I understand what the reason is that you said, that you strongly agreed with most of those, the ones that we picked out. So that those would be the ones that we want to really understand your experience around those.
Yeah.
Great. So we'll do this again in about 3 months. And, some people like to see a graph of what's happening with their scores. We'll discuss, how best to do it with you, but we'll always do it sort of like this, where we discuss it together and think about how we can best use this information.
Okay.
Okay, great. Okay. So that's introducing a measure and going through it and providing the rationale and not just, handing it to someone in the waiting room, because that is something that they're probably not going to get tremendously invested in or see the benefit to themselves.
Mm-hmm.
All right. So I think we're at the point, let's see what the time is. So it's 12:35. So we're at the point where we have some time for questions. And hopefully people have been writing some stuff in.
Yeah. And just one more thing about the assessment that we just did as this example. Hopefully you're getting the picture that assessment isn't just sort of this robotic thing that you do, that is actually therapeutic, right? That is part of the therapy, and having that kind of discussion and having Bryant, myself playing Bryant, have the experience of like, wait, these questions actually like resonate much more than I thought. It's a very stigmatizing kind of activity and exercise, and a very normalizing one too, to see that, people experience this distress. I'm not the only one out there experiencing it. And that helps me see that enough people experience it that someone actually wrote a questionnaire about it, that it's a thing, right? And that's really, really can be very eye-opening and beneficial for the client. Okay, let's take a look at some of the questions. Okay, so we've got a question about trauma. We've got some questions about empathy and theory of mind. Okay. I can start with the trauma question, Corey, and then we can do the empathy questions, and since they were from earlier on, then we can see what else we have time for after that.
Okay.
Does that sound like a plan?
Sounds great.
Okay, so the question is related to trauma and hallucinations, delusions, psychotic experiences. And so the exact question is, when I was trained in psychiatry years ago, it was said that the hallucinations and delusions with purely traumatic content in a person with adverse childhood experiences wasn't really psychosis. Of course, we know that's not true, but my sense as a psychiatrist is that meds don't touch this kind of psychosis. Is CBTP effective with this situation, which is very common in the community mental health setting? Great question. Thank you. Okay, let me just try to address this a little bit. And one of the things that I do apart from CBT for psychosis is work a lot with PTSD, trauma and PTSD in people who have serious mental illness more broadly. So the kinds of people we all work with basically, who are seen in community mental health clinics like yours. And so my colleagues and I, Kim Muser and Stan Rosenberg and some other colleagues, have done a lot of work with a particular intervention that is specifically designed to address trauma and PTSD in people who have serious mental illness alongside of it. So people with schizophrenia and psychosis, but also people with bipolar disorder, severe depression, borderline personality disorder, etc. Because as many of you know, and the person who wrote this question know very well, is that trauma and PTSD is a giant part of the clinical picture for a lot of the people we work with, specifically a lot of people who have psychosis and schizophrenia. So it's a big deal, and it's a problem. And so one of the things we were trying to do was figure out a way to address that within treatment. So I mention that because if you have someone whose sort of primary symptoms seem to be PTSD or trauma related, and they also have sort of this co-occurring kind of condition like psychosis or bipolar disorder or very debilitating depression, then a specific trauma treatment might be kind of the way to go, right? And I'm happy to if there's interest in the CR for PTSD and serious mental illness intervention down the line, Natalia or whomever else, we can certainly talk about training in that. But I do say that because if it feels like the PTSD is the driving force, then you probably would want to do that kind of treatment. That said, we do know that psychotic symptoms are often the result of trauma, right? Even for people who don't have a co-occurring diagnosis of schizophrenia or any other kind of psychosis, right? So people who have severe PTSD, even if they don't have psychosis, will have the experience of having hallucinations sometimes, right? Bringing them back to whatever the trauma was, whether it was military-based or violent, interpersonal, sexual abuse in nature, whatever it is. And so, you know, CBTP can address that kind of a thing. And tomorrow, one of the things we're going to talk about as far as case conceptualization goes is how to talk about that with the client so that they can understand the ways in which their past trauma contributed to the kinds of symptoms they're having now in terms of voices or delusions or kind of general paranoia. So that is definitely a place for that. That might be one of the client's goals or problems that you're addressing, which is, you know, kind of make more sense of what got me to this place where I hear these voices that are related to my trauma. Or be able to feel less anxious so that I can socialize with people or have some relationships. That might be one of the problems and the goals for the particular client. We're going to talk more about that tomorrow. And there are some techniques that we'll be talking about tomorrow about how to do cognitive restructuring and other kinds of behavioral coping strategies to help people whose content might be sort of trauma related find some relief from that. So hopefully that's a helpful kind of introductory answer to the question there.
Great. Thank you, Jen. We're so lucky to have Jen. This is really an area of very few people have expertise in, and it is one that Jen has developed an international reputation in. So I want to take an earlier question that we didn't get to before about deficits in theory of mind and how does that connect with empathy and how do you enhance it? And it says, it seems that some clients keep on ruminating or blaming, less self-awareness of how they could look within for a change they need. Yeah, so to some extent, you know, it's interesting because I think empathy is a big concept. So empathy is about, you know, emotionally responsive connection, often to suffering. Like that's a lot of times how we think about empathy. Like, can I connect to another person's suffering? I would say that when people are suffering tremendously themselves, it is often very hard for that alone leads to deficits in that particular type of empathy. So, you know, we do see oftentimes when people are suffering tremendously, one thing that can happen is a tremendous self-focus, that people can become really in their own head and in their own mind about their problems and their issues, and that can lead them to be a little tuned out to other people's problems and emotions. So that certainly can be operating. Theory of mind, though, might be a little bit different from that. Theory of mind is almost like it's a social cognitive skill, and we don't totally understand what happens to it. Does it like, was it never fully formed? You know, for example, in autism spectrum disorders, theory of mind is often a really difficult thing for people to do. So there's a famous experiment, and maybe this is going to be boring to people, but I always found this one really interesting, with kids who had autism and also developmentally with kids, you see this as well. So like if I play a trick on a kid who's not in the room, but I bring another little kid in as a confederate with me, and I say, look, I'm going to take this candy bar, and instead of in this candy bar, I'm going to put erasers in it, but then I'm going to wrap it all up and it's going to look like a candy bar. And when Ellie comes in the room, what is she going to think is inside the candy bar? There's an age at which it's normal for kids to say erasers because they think what's in my mind is also in her mind. That's theory of mind. Theory of mind is the information sharing of internal experiences. So people with autism sometimes have this difficulty. It's also kind of related to almost like deconstructing a television show. Like if you're sitting with your kids or
and you're talking to them about like, well, what's this person's motivation right now? What's going through their mind right now? How skillful is the kid at doing that? Kids get better at this over time. But so that's where theory of mind kind of happens, and where empathy, I think the way you're talking about empathy, maybe, I'm not sure, but where they might clash is when someone is so internally focused, they really can't shift out anyway. But theory of mind is it's a broader deficit than that, if that makes sense. So how can it be enhanced? That's actually something we're going to talk about tomorrow. We're going to talk about generating cognitive flexibility, which is a social cognitive skill. And we think that by doing that, you're actually improving people's theory of mind, or something called mentalization therapy, maybe people are aware of, the idea of being able to mentalize what's in someone else's head.
Okay, let's see. Another question to address is about when you sort of start normalization and destigmatization. That's always a mouthful. Is there a certain standard to do so? If, because the client may feel discredited if introduced early. I think, like anything, you want to read the room, right? You want to kind of have your best clinical skills on for this, but we really talk about entering into a normalization stance and a destigmatizing stance and spirit and attitude from the get-go. Now, that doesn't mean that you're going to kind of right off the bat in the very first session pile on a lot of statistics and information about the percentage of people who hear voices in the standard population and so forth. If that doesn't feel like something that is relevant to the conversation, or that would be well received by the client right away, right? So you kind of want to pace those things, but truly, you are doing normalization and destigmatization from the get-go. That's how you get someone engaged. That's how you help them feel less anxious. That's how you help them understand that this therapy is a little bit different and that you're going to really be listening and the two of you kind of working collaboratively. That said, you're also going to be using elements of normalization and destigmatization through the entirety of your course of therapy with your clients. It's not something that you just do in phase one and then it kind of stops. It's something you introduce in phase one, set the stage, but then you're going to just keep continuing to come back to that. Because when we think about the philosophy and spirit of Cbtp, that normalization and that destigmatization in spirit and then in specific practice, giving accurate information and so forth, runs throughout the entire course of the treatment. Good question.
Great next question, and something that Jen and I are very interested in. So any specific tips for use with first episode psychosis? So as some people might know, there was a big trial that was published in 2015 by John Kane as the first author in JAMA Psychiatry. And what this study was a trial of coordinated specialty care, so CSC, which is really, it's a team-based integrated model using cognitive behavioral therapy informed practices for first episode psychosis. And it consists of individual therapy, which is called, in this case, individual resilience therapy, which is based on cognitive behavioral therapy principles and infused with cognitive behavioral therapy. It's a little different from what we're describing here, which is more focused in particularly on psychotic symptoms, but it has those elements. And family psychoeducation, teaching people about a first episode of psychosis, also medication and supported employment and education to help with the functioning of these kids. So this is called the Navigate treatment model. It's actually a model that Jen and I were involved with developing. And this is currently has the strongest evidence base actually for the treatment of first episode psychosis in the United States. So those materials are actually all available online for free to everyone. It's called, if you Google Navigate First Episode Psychosis, it's actually another set of trainings that Jen and I do, and others. So it's another model. It's very comprehensive, and I don't know what else to say about it. Jen, what else would you say? There's so much to say.
Well, right. And so, yeah, so the idea of first episode psychosis and sort of the way that you would differentiate or how you would do CBTP with a younger person who's having their first experience of psychosis could be its own workshop on its own entirely. So there's sort of different ways that you would interact with the family, assuming the person's younger, the school, etc., that don't necessarily come into play in sort of standard CBTP for people who are not experiencing their first episode. So, you know, certainly that's something that we could talk more about potentially tomorrow, you know, if we have time to go into that. But definitely look up Navigate and some of those materials. And, you know, we're lucky to have Corey because she's the one of the leads and the director of the Mass General Hospital First Episode program, which was one of the first in the entire country. So she's got a lot of expertise on that and how to sort of integrate these kinds of techniques with people who are younger and who are experiencing that initial or early episode. Okay, good question. I'm seeing two questions here related to assessment, so maybe we'll address those since we just kind of came off that topic while it's still fresh. The first one is, can the assessment tool be used on children? I believe that question is in relation to the P scale or the paranoia scale that we just did the role play on. So the questionnaires and the materials that we use in CBT for psychosis that we have sent to you were designed and validated on adults. That's not to say that many of them can't be used for people who are young adults, you know, first episode clients like we were just talking about, but they have not been designed for children. Again, that's not to say that you couldn't per se use the paranoia scale for in your work with a child who might be having some of these thoughts. You know, these are sort of universal thoughts. It's helpful to sort of get at them early if you work with kids. But I think you want to be careful knowing that, you know, this instrument was not designed for that, and kind of taking into account that your young client's ability sort of emotionally and cognitively to do a questionnaire like this. So that's what I would say about using that or any of these with children. The P scale is nice though, because it's short and it's pretty basic. So I could see it being able to address some of the kinds of things that children who have these same sort of worrisome thoughts about others might be struggling with. The other question about assessment was, how often do we do assessment with the client? So one of the things that Corey mentioned early on when we were a little earlier on when we were talking about assessment was, you know, starting out pretty right away. Again, not necessarily in the first session, but sometimes when we're teaching new clinicians how to do CBTP, we sense kind of a reluctance of getting started with assessment. And I think there's a variety of reasons for that, just sort of being unsure, feeling like it's a burden for the client, feeling like it's a rapport breaker when you're first trying to get engaged. And so we sort of dispel those myths, as you might imagine. And as you saw in the role play, that assessment discussion and the delivery and the follow-up of that assessment that Corey did as a therapist was incredibly therapeutic to me as Bryant. So if you start to think about assessment as a therapeutic tool and not as sort of a chore or a box you have to check, it gets really integrated nicely into the entirety of CBTP. And so, you know, there's no hard and fast rule about how often you would be doing the assessments, but let's say what you're working on with the client are those thoughts of paranoia to try to help them feel more comfortable and reduce their distress. And let's say another goal is kind of working on structure and managing depression symptoms and sense of hopelessness. So maybe you'd be doing the BDI, the Beck Depression Inventory, and the paranoia scale. For this one particular client, like for Bryant, those are two scales that would make sense. Same with the beliefs about voices questionnaire. So let's say you were doing those, and you know, really, if you're seeing someone weekly or seeing them every other week, every 3 months seems like a reasonable time frame for reevaluating, because then just like it gives you enough time to actually do some interventions and some techniques and see how they turn out, get feedback and so forth, and then see where things are. I myself at times have used these questionnaires every session, particularly the BDI, if we are concerned about suicidal ideation, or if there's a specific kind of symptom that we are really trying to tackle as it pertains to paranoia that's really getting in the way for the client, you might end up doing it every week as just sort of the thing that gets done. But typically, unless you're sort of in that specific situation, probably, you know, every 3 months would make good sense. So those are good questions.
So I can kind of take two quick ones together here. Does someone need to be somewhat stable on medicine before beginning this? I would say no, if this is a first episode person. No, if it's a first treatment, even if it's not a first episode person. However, if it's someone who has been resisting medication and rejecting medication for many years, you're not going to get stability on medication. So you have to decide if it's worth starting this. I mean, as I mentioned before, this is meant for people who are taking medication. That's what the evidence base is. I have certainly worked with people who are not taking medication. It's challenging. Is it potentially doing some good? I think sometimes it does seem on an individual basis like it could be, but it's very difficult, as you can imagine, someone who's very acutely ill. It's very challenging. And you also need to figure out, you know, how much are you going to actually make the idea of, you know, starting medicine a goal of your work. I mean, I think philosophically for me, since medication is the recommended kind of part of treatment, I feel that I do need to do some of that kind of work with people. So it could be a little different. And then the question about, can you use CBT with someone with an intellectual disability? You can, you know, you do need to really, you know, scale everything back. You need to modify things. You may also choose to do different kinds of interventions. And sometimes it's useful to think about how CBT has been modified for children in general, to think about how you would modify it for someone with intellectual disability. But, you know, there's a lot of verbalizing, as you're kind of hearing from Jen and me. This is a very verbal therapy. It's also a very written therapy. You want to think about how is that going to go with someone with intellectual disability. And you have to have, if it's going to be in the same format, you know, you're going to have to scale everything back to something that's comprehensible.
Great. And so just in the interest of time, I think maybe we could do one more. So let me do this last one here about short-term therapy. Is it normal for individuals to receive CBTP multiple times for the same behavioral thoughts? For example, after receiving a 10-week CBTP session, a month passes and the issues resurface. Okay, so one of the things that's really important to understand is because psychosis is complex, and for some clients it's been around for a long time, the psychotic symptoms they experience, the recommendations that US and European guidelines have suggested for duration of CBT for psychosis is really about 6 months, at least. For some people, it is a whole year or even longer than that. So CBT is a short-term treatment and CBTP is a short-term treatment, but it's kind of a relative concept, right? It would be challenging to do 10 weeks of CBTP and kind of end it there. And I think part of what we want to convey is that all the stuff that we talked about today, and early on some of the stuff we'll be talking about early on tomorrow, is all sort of setting the stage for the actual coping strategies, right? So we just spent a whole workshop day on sort of how to set the stage, because you really can't just kind of dive in and start doing interventions and techniques and cognitive restructuring without kind of this engagement period, the assessment period, developing the problem list, case conceptualization, and so forth. And so that in and of itself does take some time. And if you kind of pull that piece out and go right to the interventions, it's not going to be effective. So we've learned this over time with research. So CBTP tends to be often a little bit longer than some of the other cognitive behavioral therapies. So you would want to, you know, get someone involved for about 6 months. That said, right off the bat, you don't have to tell the person, oh, well, we're going to be doing this for a year. That can be really intimidating, but you can sort of start piecemeal and sort of say, you know, let's meet for 6 weeks in a row and see how we're doing and how far we get. And, you know, you have that opportunity during those 4 or 6 weeks initial sessions to really kind of get them engaged and rope them in a positive therapeutic way, rope them in so that they'll stick with you. We're going to talk more about that tomorrow as far as the different kinds of approaches and how to you know, kind of pace what you're doing with clients overall. And then one of these other questions here, how do we get ongoing CBTP training to be certified as a practitioner? If you come tomorrow, which I hope you will, hope you all will, we will be talking about that at the very end, because there are some options, and you know, possibly within your agency there'll be some ongoing discussions about that. But we can talk about what that kind of looks like, you know, tomorrow as we talk about the other components. Okay. And we did talk a little bit about PTSD already, and then tomorrow we will be talking about how to kind of work with paranoia and sort of understand it better, and how you would address kind of certain types of paranoia with different kinds of techniques. So I think we'll be able to address that a little bit more clearly tomorrow.
I think people probably have to go. We really appreciate you being with us today, your interest. It's been a pleasure. We will see you again tomorrow.
Yeah, Natalia, maybe you have some, I don't know if you have some wrap up housekeeping stuff. Please go ahead. Thank you.